Good morning, guys. Good morning.
Morning, ma'am.
Okay.
Morning, ma'am.
So guys, 87 lang kayo. So I think madaming absent today. Okay. So please, Mayor, pakisabihan sila to send you a message, their name and their purpose. Okay. Or I mean the reason, okay, of not attending. Okay, yung class for today. Okay. So today we'll discuss no about microscopic examination of urine. Okay. And I hope natapos nyo po yung recorded lecture natin sa chemical examination of urine. Okay? So for the microscopic exam of urine, okay, we have here the purpose, okay? And sabi nga natin, 'di ba last time before, okay, nung kauna-unahan ang ginagawa nila okay in the examination of urine is to observe the physical, okay, properties okay of our urine, like for example, they do observe yung color, okay, nung ating urine, yung clarity niya, o kaya yung odor. Okay, nalilimit lang, okay, yung examination that time. Siyempre, because during those times, okay, wala pa tayong development ng mga machines natin, of course, our chemical reagent strip. So, limited, okay, yung examination ng urine to physical examination lang, okay? But of course, due to advent or improvement in technology, okay, we have now yung chemical examination through the use of your reagent strips, mga ganyan, okay? So, by the way, naalala ko pala yung tanong ni Erica last time. She asked me how glucose, okay, in urine, okay, is being measured. So, Erica, yung nasagot ko sa'yo last time is, for example, the measurement of glucose in your 24-hour urine. So they do that, okay? They have machines, okay, in measuring the way almost similar, okay, with the methods they use for blood, okay? So that's for the quantitation, okay, of your glucose. But also for other methods, kung na-encounter mo siya, nakalimutan ko actually, okay, nung nagtanong ka, medyo nalito ako, okay? Ang answer dyan, other than the use, okay, of the method that I mentioned last time, is of course yung use ng chemical reagent strip mo and other related methods, like for example, the use of your cleaning test, okay, and other tests depending now on the type of carbohydrates. Okay, but for glucose, we have for example, di ba yung sa chem exam ninyo, we have the use of your glucose oxidase test, mga ganyan, your cleaning test, yung copper reduction test ninyo, mga ganun. Okay, so again, we have here the microscopic examination of urine. So sabi niya, the purpose, okay, of your microscopic exam is to detect, okay, and to identify insoluble materials present in the urine. Okay, so guys, in most laboratories, after your chemical and your physical examination, we perform na yung microscopic exam. Pero mamaya may makikita kayo dyan na discussion natin, we have macroscopic screening or the chemical sieving, where some laboratories, okay, do not necessarily perform microscopic exam. They just perform the microscopic exam when physical exam and chemical examination results suggest, okay, or recommend. So like for example, sabi natin, di ba, dun sa physical examination of urine, kapag nakita natin na yung kulay ng urine natin red, di ba, that will give us a hint na, baka sa chemical exam, I'll expect presence of, positive results for your RBCs, okay? Or microscopically, I can see presence, okay, of intact red blood cells, mga ganun. Okay? So in some laboratories, sabi ko nga sa inyo, hindi sila nagpe-perform kaagad ng microscopic exam unless, okay, the physical and chemical exam results suggest or recommend. Okay? So sabi niya, it's used to detect and identify insoluble materials that are present, okay, in the urine. So these materials, they can be what? Materials coming from our circulation, blood circulation, like for example, the like of your blood cells, yung white blood cells nyo, yung red blood cells ninyo, okay? Or sa mismong kidney natin, for example, in patients with renal failure or patients with infection involving, for example, yung kanyang kidney, okay? O kaya yung kanyang bladder, okay? So, pwede nating makita, okay, yung mga insoluble materials na to sa urine, okay? And that will aid now the physician in making his or her diagnosis, okay? So guys, we have here, examples or the enumeration, okay, of the different insoluble substances or form elements in urine. We have number one, yung red blood cells natin, and then we also have yung white blood cells. So adding, okay, so guys, no, wait lang ah. So the presence of your red blood cells and white blood cells, okay, may indicate normal, okay, or abnormal conditions. When they're in high amount, pwedeng abnormal, okay, yung cause, okay, or pwede namang normal lang. Like for example, your red blood cells, okay, they can be seen, okay, or readily observed sa urine natin, lalo-lalo na halimbawa kapag yung tao ay nag-undergo ng strenuous exercise and still considered normal. So after resting, nawawala din siya. So transient lang, okay, yung hematuria na yon. Okay? But of course, in infection, for example, like in your pyelonephritis or your cystitis, makakakita tayo ng large amount of white blood cells or sometimes presence din ng red blood cells natin, especially pag severed na yung tissues doon sa ating kidneys. Okay? Like for example, in pyelonephritis or your upper UTI. Okay? So, values of, for example, 0 to 2 for your red blood cells and white blood cells, normal pa yon. Okay? Normal pa rin yon. Okay? So, next, we have also presence of your epithelial cells. So, adding dun sa mga epithelial cells natin, example, nung nakikita nating epithelial cells, we have your squamous epithelial cells. Yung normal siya, okay, na nakikita. Like, for example, di ba, sabi natin last time, among female patients, okay, or among pregnant women, for example, di ba, we recommend, okay, them to collect specimens ng midstream. Okay, bakit? Kasi, for example, yung patient mo, hindi siya nagpaupaw, for example, madaming mga vaginal squamous epithelial cells. Okay, and that's still considered normal. Okay, but other epithelial cells, okay, that we can see, for example, yung mga renal tubular epithelial cells natin or yung mga tinatawag nating RTE. Yung mga RTE nyo, guys, presence of those with amount of more than 2, okay, per high power field may indicate problems dun sa kidney natin. So since we say they're renal tubular epithelial cells, ibig sabihin they're the cells found in the lining of our tubules. So in infection, for example, or in diseases, okay, that cause now damage dun sa tubules natin, madalas nakikita natin sila and they're considered significant. Okay? What else? We have, for example, din yung mga transitional epithelial cells natin or yung tinatawag nyong urothelial cells, okay, in human histology. So yung transitional epithelial cells natin adding, they're considered normal, okay, but they're usually seen, okay, in large amount, okay, or in large number when, for example, the patient no has malignancy o kaya naman infection, okay, that involves yung ating bladder. Like for example, your cystitis. Okay? So mamaya pag-aaralan natin adding yung iba't ibang uri ng RTE cells ninyo, yung iba't ibang uri ng transitional epithelial cells ninyo, and of course the different, okay, types or the different forms of those cells. Okay, so hindi lang kasi lahat sila bilog, and of course the difference, okay, between your RTE and that of your transitional. Kasi like for example, for your spherical, okay, transitional epithelial cells, kamukha niya, okay, yung round RTE natin. So how are we going to differentiate, okay, yung dalawa na yon? Okay. And then what else? We also have casts. Okay? Sabi niya cast lang yung malakas. Okay? So casts, guys, okay, we're talking about cylindrical, okay, structures na merong balot. Okay? So they're actually with a matrix. Okay? Sa loob nun are different components. So pwedeng red blood cell if that's a red blood cell cast, okay? Or pwedeng granules, for example, if that's a granular cast, okay, coming from the degradation or disintegration of other casts or cellular casts. O kaya pwede namang bacteria yung laman niya, okay? And then we call that your bacterial cast. O kaya WBC cast, we call it your WBC cast, okay? So adding yung mga cast natin, katulad ng ibang mga form elements natin, pwedeng nakikita sila sa urine in non-pathologic conditions. Halimbawa, yung hyaline cast ninyo, pwede po natin siyang makita, like for example, among individuals no, who undergo strenuous exercise, pero after a while, nawawala din sila. Okay? But of course, cast like for example, yung waxicast natin, broadcast natin, presence of those, okay, will tell you, okay, that that patient, okay, may have no renal failure or is suffering from renal failure. Okay? So like for example, 'di ba, yung broadcast natin that indicates what damage doon sa ating tubule, okay, doon sa ating DCT for example or in the collecting tubules. So nung nangyari, nagkaroon ng widening, okay, nung tubules na yon due to underlying, okay, conditions, okay, that lead to your or that leads to your ang tawag dito, chronic renal failure. Okay? So next, we also have bacteria. Okay? So adding for bacteria, pwede tayo makakita doon sa microscopic exam natin ng urine, sabi dyan. But you also have to take note, just like any other form elements, pwedeng yung presence, okay po, ng bacteria natin ay pathologic o kaya naman non-pathologic. Okay? So example, for non-pathologic causes, we have contamination. Diba? Lalo kapag unpreserved yung urine natin at in-examine natin siya under the microscope, pwede ka makakita ng presence ng mga bacteria. And those are contaminants. Okay? So kailan natin malalaman na ma'am yung bacteria ba na yun ay dahil sa contamination o baka naman ma'am yung bacteria na yun ay dahil sa isang infection. Okay? We can, okay, determine that by, checking into presence of your white blood cells because a true infection, okay, would how do you call this one, show you presence, okay, of white blood cells other than the bacteria. So kung solo bacteria lang yan, malamang sa malamang baka contamination yan. Okay? So what else? We have also presence of yeast and your parasites. Okay? So halimbawa adding, di ba kailan tayo nakakita? For yeast, pwedeng contamination o kaya naman dun sa mga pasyente natin na mga diabetic patients, di ba? Example, yung mga female patients with infection, okay, or yung infection with Candida albicans that we call moniliasis. So nakakakita tayo ng mga budding yeasts, di ba, yung mga pinball appearance, so bilog siya tas may maliit pa na ganun. Okay? So what else? Parasites, di ba, na-discuss nyo before adding sa parasitology ninyo, for example, presence of your schistosoma hematobium ova o kaya naman yung pinworm ninyo egg, I'll call this one, Enterobius, di ba, vermicularis, yung D-shaped egg niya. So, or ova niya, pwede nating makita sa urine. Okay? And then we also have presence of mucus, okay, that we often consider or usually consider as non-significant, okay, but may be increased in some conditions. Okay? And then we also have sperms. So, pwede tayo makakita po ng sperm dun sa urine. So, pwedeng sa male, pwedeng sa female. Okay? If that's for the male patient, normal lang. Malay mo, katatapos niya sigurong nag-masturbate, then nag-urinate siya. O kaya naman, pwedeng significant. Like for example, among male patients, okay, na infertile, okay? Like for example, yung mga pasyente na meron tayo tinatawag na retrograde ejaculation. So kapag ka umiihi sila, nasasama yung semen nila, okay, doon sa ihi. Kasi diba isa lang yung labasan ng ihi nila at saka nung semilya. So nangyayari, nagkakaroon ng problem, okay, doon sa sphincter, okay, that separates now, or I mean that closes, okay, yung bladder nila pag naihis sila or pag nag-ejaculate sila kakusana. So dahil nagkaroon ng sira dun sa sphincter na yon, during ejaculation napupunta yung semen nila doon sa bladder instead na lalabas siya kaagad sa urethra. So napupunta siya sa bladder, namimix siya sa urine. Okay? So yung mga pasyente po na yon, they're at high risk, okay, of infertility. Okay? So or among female patients, like for example, female patients no na nag-collect ng urine just after coitus, okay, or sexual intercourse with her partner, for example. O kaya naman in young children, for example, di ba, pwedeng suspected case yon. So we have to determine if the detection of that has a legal consequences. Okay? And then we also have presence of crystals. So we'll be discussing the different crystals seen in urine. So meron tayo guys yung mga crystals found in your acidic urine, those that we can see in your alkaline urine. Okay, yung mga normal, okay, and abnormal crystals. And of course, the identification of these crystals. Kasi meron yung mga magkakamukha, okay? And kahit magkakamukha sila, nadi-differentiate natin sila because of what? Their, or I mean the pH, okay, of the urine. Like for example, yung mga amorphous materials natin, so 'di ba parang grainy sands sila. Okay? So pag nakita nyo sila, hindi mo alam if it's that amorphous ureates or amorphous phosphates. So that the first thing that you need to do is of course to check for the pH. If the pH of the urine is acidic, then we can say that that's your amorphous ureate. If it's alkaline, then that's your amorphous phosphate. Okay? And then, of course, presence of artifacts. Example, okay, yung tissue paper natin, 'di ba, yung fiber niya, minsan nakala natin important formed elements 'yon, pero artifacts lang sila, contaminants, okay? So or for example, yung mga air bubbles, 'di ba, kapag ka nag-examine tayo ng urine ninyo, 'di ba, nilalagay natin sa slide and sometimes we add, 'di ba, cover slips. So minsan, pag di natin na mimix or I mean di na-spread ng mabuti yung urine, nagkakaroon ng bubbles, air bubbles doon sa ilalim ng glass slides natin. So nakikita natin sila. Okay? And presence of those, okay, pag kunwari na-examine natin siya under the microscope at nakita natin sila, kunwari nakakita tayo ng air bubbles, isang indication nun na wala ka pa dun sa right plane of view. Okay? So you have to adjust pa, okay, yung fine adjustment mo kasi nasa ibabaw ka pa lang. Okay? So for your artifacts, madali lang natin silang makita. Bakit? Kasi compared dun sa mga significant form elements natin adding, yung mga artifacts po natin, they're usually highly refractile. Okay? Pagka inikot-ikot mo yung fine adjustment mo, parang kumikinang-kinang sila. Okay? And other than that, mas visible sila compared dun sa form elements mo. Yung mga form elements kasi natin, they have no low refractive indices. So, mag super bright yung ilaw mo, ang hirap nila makita. That's why we have to examine them, okay? Lalong-lalo na pag nasa LPO tayo, okay? In reduced light, okay? Unlike dun sa artifacts mo na kahit mababa yung ilaw mo, okay? Kitang-kita mo sila, very visible sila. Or even lalo, kapag ka malakas, okay, yung ilaw mo, kitang-kita mo sila. Okay? So guys, no, your microscopic exam is least standardized compared to that of your physical and the chemical examination. Ibig sabihin adding the laboratories or I mean the microscopic exam, okay, results, okay, sa isang lab may vary from the results that we get from other laboratories. So it depends dun sa protocol nila. Okay? And of course, it's the most time consuming. Kasi after chemical examination, what you're going to do, di ba, you have to centrifuge it, then examine, okay, scan yung iyong urine under the microscope. But of course, no, in automated systems, okay, madali na lang siya gawin kasi si machine na mismo, okay, yung gagawa nun. Or I mean, for automated systems or for more standardized system, I should say, okay, mas okay siyang gawin or mas accurate, okay, yung nakukuha nating result at pare-pareho within the lab kasi standardized nga siya. Okay, so like for example, they provide kasi, okay, yung pipette that we use. We also have a specialized slide where we can view the sediments. Pero sa manual kasi, like for example, dun sa mga makikita nyo sa lab natin dito, sa mga hospitals or clinics, least standardized. Bakit? Kasi we do manual examination. We just use the typical glass slide, okay? And sometimes we don't pipette pa yung sediment natin. What we do is just to pour it, okay? So that makes it least standardized or less standardized compared to those protocols, okay, that are being in place dun sa mga high-end labs natin. Okay? Okay, so next, so adding we have here a picture showing to us yung mga possible, okay, form elements na makikita po natin doon sa ating urine. So kung makikita nyo dito adding, these are your white blood cells, okay, itong malalaking arrow na to. And these ones here are your red blood cells, yung mas maliliit, okay? So this one naman, okay, ito. So we have here yung inyong mga, how you call this one, crenated, okay, red blood cells. So adding, kung makikita ninyo, yung white blood cells ninyo, mas malalaki sila compared dun sa Tama ba? O tama. White blood cells are larger, okay, than your red blood cells. Okay, di ba alam nyo naman yun sa hemanure, sa basic histology. And other than that, kung papansinin nyo guys, yung white blood cells po natin, mas madumi yung loob niya. May mga granules and you can see their presence of the large nuclei. Okay, for usually nakikita natin dito mga neutrophils. Okay, so ma-observe nyo yung kanilang multi-lobe nuclei. Okay? Compare dun sa red cell ninyo, mas maliit sila. Minsan makikita mo sila double-walled, okay? Because of the biconcavity. And of course, clear yung loob nila. Okay? But sometimes, just like here, makikita nyo sila, no, medyo, tawag dito, may parang giting-giting yung borders nila. Okay? Those are your crenated red cells. Saan natin to madalas makita ading? Di ba? Dun sa mga urine natin with high specific gravity. Okay? So, crenated sila. Okay? Hyperstenuric urine. Okay? So, we can see here, okay, yung mga crenated RBCs natin. So, kung makikita nyo guys, parang glittery yung appearance nila. Hindi na sila kasing, kung makikita yung borders ng mga normal red blood cells dito, very definite yung border. Dito hindi. Parang mga giting-giting or I'll call this one, parang jogged, okay, yung mga borders niya. Okay? So those are your crenated RBCs. So again, yung mga malalaki dyan, those naman are your white blood cells. So ito po yung isa sa example, okay, nung possible microscopic picture ng urine natin. Okay? That we can see of course under your microscope. Okay? So next we have your macroscopic screening or chemical sieving. Okay? So adding your microscopic exam, sabi niya, is performed based on the physical and chemical results. So sabi ko nga sa inyo, yung ibang laboratories guys, nasa protocol nila yan that they perform physical, chemical, and microscopic exam. But there are those laboratories that perform only microscopic examination, okay, when physical and chemical results suggest, okay? So kapag nakita nila, like for example, that the physical appearance of the urine is red in color, it's turbid, okay, other than that, there is no positive result for blood, there is, for example, positive result for leukocyte esterase, then that gives them a hint na we should observe it under your microscope or examine it under your microscope, okay? But in most of the laboratories na mapupuntahan ninyo pagdating ng araw, lahat, okay, nung examinations na to pine-perform natin. They don't do, okay, chemical sieving, okay? Or I mean, they try to observe physical, or I mean, they use the observation in the physical exam and the results in the chem exam to, at least have an hint, okay, kung ano makikita nila microscopically. But still, they perform, okay, microscopic exams. Okay? So, sabi ko nga, for example, pag nakita natin na clear yung urine natin, okay, the color of the urine, for example, is straw color. Tapos, in the chem exam, halos negative lahat yung results natin. So, nagkakaroon na tayo ng thinking sa, or notion, okay, na pag na-observe ko to under the microscope, malinis yung urine na to. So, it's true, malinis siya. Wala kang makikita. Siguro, kung meron man, mga squamous cells lang. Okay, and normal amounts of your white blood cells or red blood cells. Okay? So, what are the different, okay, things, okay, na ginagamit natin or parameters, okay, that we use now to determine the need, okay, for microscopic examination? Number one is yung kulay, di ba? Sabi natin, ay, pag nakita natin na red yung urine, baka mag-positive ito dun sa chem exam natin. So, red yung urine mo, tapos sa blood result mo sa chemical exam, nag-positive din siya, for example, or 3+ siya, for example. So, in-expect mo na sa microscopic exam, baka makakita ka nga ng sobrang daming red blood cells. Okay? Or for example, sa clarity, kita mo turbid, napaka-turbid ng urine mo. Okay? So, na-expect mo na, tapos sabi ng pasyente na masakit yung pag-ihi niya, mayroon ka na idea na, baka makakakita ako dito ng napakaraming mga white blood cells, mga pus cells. So, pwedeng may UTI yung pasyente natin. Or like, for example, urine clarity, kapag ka, for example, nakakita ka ng clear red urine, okay? So, di ba, it will give you a notion na, makakakita ako nito nung or I mean, hindi ka pala makakita kasi for clear red, we have for example, no, hemoglobinuria or myoglobinuria. So pwedeng chem exam mo positive, pero pagdating ng microscopic exam, pwedeng wala akong makitang mga red blood cells or meron man kakonti lang that doesn't correspond the result ng chemical exam. So baka kasi ang reason is hemoglobinuria or myoglobinuria. Okay? So, or for example, pag cloudy red naman siya, okay, yung urine mo, at positive result din, okay, yung chem exam mo, so i-expect mo na makakakita ka ng mga intact red blood cells natin. Okay? What else? We also have presence of protein. Okay? Diba? Like for example, when there's positive result or strongly positive result for protein, okay, and other parameters like blood, okay, leukocyte esterase, like for example, sa mga renal failure patients, expect na natin tong patient na to turbid pa yung urine niya, baka makakakita ako nung mga how do you call this one? Casts, okay, or urine cast niya, okay? What else? We also have your nitrite and your leukocytes. So adding no, yung leukocyte esterase natin pag nag-positive siya, okay, sa chemical exam, expect natin na if it's a true infection, nitrite pala yung tinuro ko. Kapag nag-positive ka ko sana, yung nitrite natin, okay, dun sa chemical examination of urine, okay, if it's a true infection, dapat positive din yung leukocyte esterase mo. Okay, that will tell you that there's really an infection, okay, dun sa patient mo. But if, for example, nag-positive yung nitrite mo adding, pero negative yung leukocyte esterase mo, and if you look into microscopic exam, wala ka namang makitang WBC, baka contamination lang yun. Okay? But, what if, for example, ma'am, negative naman yung nitrite ko kakusana, pero positive naman yung leukocyte esterase ko sa chem exam, and I can also see presence of many white blood cells microscopically. Can I consider that an infection? Yes, kahit negative si nitrite. Ibig sabihin, maaaring yung nagkukos ng infection dun sa pasyente ay bacteria that is non-nitrate reducing. Like for example, yung mga staphylococci ninyo, mga ganun, or enterococci. Okay? So again, positive nitrite, okay, result in your chem exam with a negative leukocyte esterase and no WBC under the microscope may indicate contamination. Okay? Kasi ang true infection, dapat kung positive siya sa nitrite, positive din siya sa leukocyte esterase, and makakakita ka ng mga WBC sa under the microscope. Okay? Pero what if, for example, ma'am, nitrite positive siya, ma'am, nakakita naman ako, ma'am, ng mga WBCs, nitrite positive siya, ma'am, tapos negative yung leukocyte esterase niya, pero sa microscope exam, nakikita ka naman ako ng madaming WBC. Baka yung WBC mo, crenated. So since they're crenated, hindi nila na-release yung kanilang leukocyte esterase. So di ba yung leukocyte esterase, sila yung dinedetect ng reagent strip natin. So kaya siya nag-negative. So that's false negative for your leukocyte esterase in the chem exam. Bakit? Kasi nakakita ka ng white blood cell doon sa microscopic exam mo, kaya lang crenated sila. Okay? So that still may indicate true infection. Okay? What else? Presence then of your glucose, okay? Kunwari, nag-positive yung chemical exam mo sa glucose, okay? Ano expect mo microscopically? Yung patient ko na to, diabetic, baka makakita ako ng mga budding yeast, okay? Or for example, a mycelial form of yeast, for example. Okay? So, na-expect mo na, okay? Nagkakaroon ka na lang ng forecast, okay? Kung ano yung magiging result ng microscopic exam mo, okay? So also we have to have no protocols in place for special populations. Example, for pregnant women, okay, for pediatric patients, geriatric, and your diabetic and immunocompromised patients. Lalong-lalo lang for renal patients, okay? So like for example, when we see presence of broadcasts, okay, and other significant abnormal results, we have to immediately report that, okay, dun sa attending physician, okay, nung ating pasyente, okay? Ibig sabihin, the values are critical and we have to report it immediately, okay, for the treatment and of course, immediate treatment, okay, nung pasyente natin, okay? So again, these are examples, okay, of the parameters, okay, that we try to check, okay, dun sa chemical examination result natin at sa physical exam result. And they will actually give us an hint kung ano yung mga bagay na pwede nating makita microscopically doon sa urine natin. Okay? So next, we have here the recommendations by CLSI or your Clinical and Laboratory Standards Institute. Sabi niya, kailan daw tayo magre-request or kailan daw tayo magpe-perform ng microscopic exam dun sa urine. So we have here 4 conditions. Number 1, when it's requested by the physician, or when it is, okay, or when the specimen, I should say, okay, is coming from a laboratory specified population. So for example, that's a diabetic patient. So important, okay, na i-check natin. Baka may presence of pudding yeast, okay? Or if that's, for example, a renal patient. So we have to check, baka may presence na nung broadcast natin, waxicas, that may indicate that that patient actually has or already has, okay, end-stage or chronic renal failure, okay? So any abnormal physical or chemical results, so di ba yung macroscopic sieving natin or screening natin. So sabi niya, kapag daw nakakita tayo ng abnormal results sa physical exam natin or sa chemical result, then we have to examine, okay, the urine under the microscope, okay? And what else? Laboratory criteria are programmed into automated instrumentation. So for some laboratories, they have, okay, automated instruments, okay, that are pre-programmed to determine now the need, okay, for microscopic examination. Okay? So next, okay. So guys, no, wait lang ha, magsi-CR lang ako, saglit lang. Okay. Hello? Naririnig niyo ba ako, Adi?
Hello, ma'am.
Yes, ma'am.
Okay. So guys, no, next we have here yung sediment standardization. Okay, so here we're talking about the preparation of the sediment, okay, the volume, and then the methods of visualization, and of course, the reporting of results. Okay? So, sabi ko nga, for some laboratories, they have standard protocols. Okay? So, they use commercial systems like yung COVA ninyo. So, in COVA, okay, yung supplier, they provide you the following. They have already yung calibrated centrifuge tubes. Unlike kasi when we're not using commercial systems, di ba? Ang ginagamit lang po natin is yung typical tube, okay, for urine. Okay, and then they also have special slides to control the volume. So kung nakakita na kayo ng hemocytometer sa hematology, parang ganun na mini version, okay, nung hemocytometer natin. So they are designed for urine. Okay? So ginagamit 'yon, okay, to standardize the volume, okay, of urine examined for microscopic exam. Okay? And then we also have decanting pipettes. So 'di ba sabi ko nga sa inyo, for non commercialized systems or for non standardized systems, like for example when we do manual, okay, exam sa natin sa lab, minsan di na gumagamit, okay, yung technologies ng pipette. Ginagawa lang nila is the pouring technique, okay. So after centrifugation, quick pouring lang, okay, tapos yung sediment na maiiwan, yun yung examine nila, okay. But for commercialized systems like COVA, they provide decanting pipettes, okay. They also have grids for better quantitation. So yung grid na ito, adding example, when you have to this one, determine kung may exact volume ba yung urine mo. So yung centrifuge nila or centrifuge tubes, I should say, are calibrated. And other than that, the special slides, okay, kung makikita nyo, meron silang grids, okay, meron silang graduations, okay, parang kamukhaan nga nung hemocytometer ninyo, okay, for us to standardize the counting, okay, of the firm elements under the microscope. Okay, so we have here a picture of the COVA, okay, so it's the COVA collect pack. So kung makikita nyo, meron siya nung mga how do you call this one, yung graduated cylinder tubes. Dito kasi walang makikitang mga tawag dito, mga graduations, okay, meron yan, okay, they're calibrated then, okay. They also have here yung decanting pipettes para makuha natin yung sediments na examine natin, and then they're going to place, okay, yung sediment na yon dito sa ating special slide. So kung makikita nyo, this special slide has 10 slots, so we can process, okay, the 10 specimen, okay, in this specialized slide. Okay, so kung makikita nyo dun sa gitna, guys, meron siyang parang square portion. Doon yung mid portion nung ating counting area. Okay, so doon may parang mga grid siya kamukha nung sa hemocytometer ninyo. So the how do you call this one? The area, okay, of this is usually 3 mm by 3 mm. Okay, so dito natin ini-examine under your microscope. Okay, so next we have here the different macroscopic screening correlations. Okay, so guys, we have here the screening test and of course their significance. So na-discuss na actually natin to kanina. Okay, so di ba when we this one, examine the color, okay, of our urine, kapag red siya, pwedeng may presence ng blood. So pwede kasi na hemoglobinuria yan if it's clear red, di ba? Hemoglobinuria or myoglobinuria, or pwede kasing cloudy red, okay, in hematuria. So presence of intact red blood cells. Okay? What else? Pagka yung clarity ng ating urine din ay, for example, it's turbid or for example, it's clear. Yung turbidity, sabi ko nga, pwedeng, sabi niya dyan, pathologic ang cause or non-pathologic. Okay, so for example, for non-pathologic causes, the female patients or female patient, di ba, nangalat specimen, hindi midstream, for example, random specimen, and other than that, hanga nagpawpaw, so napakadaming squamous epithelial. Very common siya, guys, lalo na sa mga pregnant women. So turbid siya, pero under the microscope or even the chem exam, wala namang mga significant results. Okay, so normal naman sila, pero napaka-turbid. So that's non-pathologic. Okay, what else? For pathologic causes, like for example nga, pag punong-puno siya ng formed elements, di ba? Halimbawa, yung pregnant women natin, meron siyang UTI or urinary tract infection, kita mo, dumi-dumi ng urine other than presence of numerous squamous epithelial cells na gadupay, tipas cell na, or yung mga white blood cells niya. Okay? What else? Red color, okay, in our urine may indicate what? presence of your red blood cell or yung mga red blood cell cast natin. So ang example nito ading dun sa mga pasyente po natin na merong glomerular damage. So 'di ba na-discuss natin before dun sa physical exam. So we can see presence of this, like for example when there's a damage dun sa glomerulus. Okay, 'di ba yung glomerulus, it's the one that filters, 'di ba, yung blood. So yung mga blood cells natin normally hindi sila bumababa dito sa PCT. So kung ito yung ano natin, afferent and efferent, bumabalik sila dun sa circulation natin, hindi na sila bumabagsak. But in patients with glomerular damage, hindi na bumabalik sa circulation, napupunta sila sa urine, kaya nakikita natin sila. Lalo na kung kunwari yung pasyente natin ading may glomerular damage at naging, okay, for example, renal failure yon. So in the presence, okay, of your urine stasis, when we say urine stasis, nagkakaroon ng retention ng urine dun sa kidney tubules niya. So pwedeng yung mga red blood cells na yon, naiipon sila dun sa tubules, tapos nagpo-form sila as RBC casts. Okay? So that may indicate what? A more serious problem. Okay? Na dapat i-check natin. Okay? So next, we have also presence of protein. Okay? So pag positive result tayo sa protein in your chem exam, expect mo mayroon kang maring presence ng mga cast or ng mga cells natin. Okay? What else? Your nitrite. Sabi natin if it's positive sa chem exam for nitrite, okay, for a true infection, that should be positive with your leukocyte esterase din. Okay? At makikita ka under your microscope ng bacteria at ng WBCs. Okay? Eh ma'am, what if for example, ma'am, meron siyang bacteria pero wala naman siyang WBC? So maaari, contamination yan. Hindi yan true infection. Okay? It should be accompanied by your WBCs. So we can consider it as a true infection. Eh ma'am, paano nga ulit kung kunwari ma'am, negative siya sa nitrite, nag-positive po siya sa leukocyte esterase, tapos may nakita po akong bacteria at saka may WBC under the microscope. So true infection ba yun ma'am? Oo, pwedeng infection yon. Or I mean, it's a true infection. Nag-negative siya sa nitrite, baka kasi nga, yung bacteria na nagkukos ng infection ay non-nitrate reducing bacteria. Example, yung mga staphylococci natin, mga ganun, yung mga enterococci natin. Okay? So that's for your nitrite. What else? We also have your leukocyte esterase. So nabanggit ko na siya kanina yung relationship niya kay nitrite at kay WBCs. So ma'am, pwede ba ma'am na positive siya sa leukocyte esterase pero kunwari strongly positive siya, for example, sa leukocyte esterase ma'am, pero the amount of WBC na nakikita ko microscopically doesn't correspond dun sa chem exam result. Medyo mas kaunti yung WBC na nakikita ko. Pwede. Okay? Pwede kasi na yung mga WBCs na iba na ay na-lyse sila. Okay? Na-lyse na sila. Okay? And ma'am, what if for example, na strongly or I mean faintly positive yung leukocyte esterase ko ma'am, or weakly positive siya pero nakakita ko ma'am ng sobrang daming WBC. Ano namang ibig sabihin nun? Kasi baka nga yung WBC mo naman ay crenated. So if they're crenated, okay, maaari hindi na nila na-release yung leukocyte esterase. Ano ba yung dinedetect ng ating reagent strip? It's the leukocyte esterase. Okay? So next, what else? Pag nakakita tayo ng positive result for glucose dun sa ating chemical exam, then i-check natin, okay, dun sa microscopic exam natin, baka meron tayong presence ng budding yeast. Okay? So next. Okay, so next we have still under specimen preparation. Sabi niya, when we examine urine, okay, for patients, we should examine fresh or preserved urine. Bakit na nga ulit hindi natin dapat examine yung urine past 2 hours of collection, after collection? Kasi, Aliyah, si Jericho. Jericho. O si CJ. CJ, bakit kailangan fresh or preserved yung gamitin natin in the microscopic exam?
Ma'am, kasi kapag hindi po fresh, magbabago na po yung mga composition po niya.
Okay.
Po ng increase and decrease po sa mga components.
Okay, yes, okay. So tama si CJ, okay? Kasi 'di ba malala niya dun sa intro ba 'yon? Sa intro to urinalysis, okay? 'Di ba sabi natin kapag unpreserved yung urine mo, for example, ang trinasis mo is a urine no after or past 2 hours after collection, okay? So more than 2 hours na siya unpreserved, okay? 'Di ba may mga parameters tayong affected. So ang pwedeng mag-increase, pwedeng mag-decrease. Example, 'di ba yung mga unpreserved urine natin nung nangyayari guys, dumadami, okay, yung bacteria niya. So pwedeng magkaroon ka ng sobrang daming bacteria. Other than that, kapag nagiging mas alkaline yung urine, nangyayari, nagkakaroon tayo ng lysis, okay, ng mga form elements like your blood cells. What else? Yung mga cas natin, nagdi-disintegrate na rin sila. Okay, so pwedeng ma-miss natin sila doon sa ating microscopic exam. That's why it's very important to use fresh or preserved specimen. So for preserved specimen, ang pinaka-common, di ba, na ginagamit natin is yung refrigerated specimen natin. But again, you have to remember that before, okay, examining a, how you call this one, a preserved, okay, specimen through refrigeration, anong gagawin natin guys? Kailangan natin siyang ibalik sa room temperature. Bakit? Kasi kapag i-examine mo yan na kagagaling sa ref, kaagad-agad, mayroong precipitation ng crystals dyan. And what will it cause? Magkakaroon tayo ng tawag dito, or it will obscure, okay, yung mga important, okay, urine sediment constituents na makikita dapat natin or dapat nating makita. Okay? So next, we also have here yung midstream clean catch specimen. Ano na nga ulit yung importance ng collecting midstream clean catch instead of just random specimen? Diba? For female patients lalo na, for us to have a less contaminated urine, lalo na with your epithelial cells, like your squamous epithelial cells, para ma-wash out. So like for example, may mga pasyente siguro tayo na hindi pa naliligo, pumupunta ng ospital para magpa-collect ng urine. For example, anda pa yung nagpaupaw, di ba? So we instruct them, okay, to give us a midstream clean catch specimen. Okay? So of course, just like dun sa natin, sa intro to urinalysis, we of course give them instruction, okay, using layman terms. Huwag tayong gumamit nung medyo technical na terms, baka di nila tayo maintindihan. Anya ajay midstream clean catch, mamahang kumaawatan. Okay? Kung kailangan mong pasimplahin, okay, yung ibig mong sabihin, gawin mo para maunawaan ka. Okay? So next, mix specimen before decanting to the centrifuge tube. So adding, di ba sabi natin, we have here the container. So ano na nga ulit yung volume niya? Approximately 50 ml. Okay? Yung container natin na ginagamit. So ang gagawin natin pagka-receive natin sa lab, we mix it or we swirl, okay, itong specimen container na to, okay? We make sure na mag-mix yung mga specimens or yung specimen natin para limbawa, seated siya for a while, baka 15 minutes na siya nasa countertop, nagsettle na yung mga formed elements sa ilalim, okay? So bago mo i-centrifuge, i-mix mo siya, okay, para magkaroon tayo ng equal distribution ng mga formed elements. Then after that, we centrifuge. Pero after centrifugation, okay, at di ka pa nag-decant, okay, wag mo namang wag mong imimix kasi sayang naman yung centrifugation mo tapos imimix mo lang din, 'di ba? So you have to remove muna, okay, yung fluid. And then how you call this one? Recover first, okay, yung iyong sediments bago mo ulit siya i-mix. So yung sediments na mismo yung imimix natin, okay? So that's for the specimen preparation, okay? So next, okay, so for the specimen volume adding, we have 10 to 15 ml of urine, okay? Or approximately 12 ml, okay, ng urine yung kailangan natin, okay? So bakit? Okay guys, no, you have to take note, hindi as much as possible, lalo na for pediatric patients, minsan nahirapan kasi tayong mag-collect kasi kukunti nga yung naiihi nila. So doon tayo nagkakaproblema, lalo na for pediatric patients, lalo sa chem exam, ang hirap, di ba, na ilublob o kaya i-soak, okay, yung iyong reagent pagkakaunti yung urine. Okay, so yung iba na absorb pa nung pad mo, pagdating mo sa microscopic exam, sobrang kakaunti na lang siya. So we make sure approximately 12 ml. Lalo kung adult naman yung pasyente natin, okay? Kung there's a need for us to do repeat collection, lalo kung nasa ward naman siya, then we ask the nurse, okay, to recollect. Okay? So sabi niya guys, no, always cap tubes. Bakit? Okay? That's to avoid spillage. Okay? Or for example, pag nag-centrifuge tayo, di ba ading na naiwasan din natin, okay, na magkaroon ng generation ng mga infectious fumes natin. Okay? Na nalalanghap natin. Okay? So sabi niya, too little volume. Okay, it means fewer formed elements. Okay, at minsan di po natin to naiwasan lalo na no among pediatric patients. Okay, so kakaunti lang yung urine nila. So for some laboratories, they do correction, okay, for volume. So like for example, sabi natin ang accepted volume should be at 12 ml. Pero yung specimen mo, for example, or the specimen of the patient, ay nag-submit lang siya, for example, ng 5 ml. Okay? So, you have to multiply that, okay, by 3. Or if, for example, it's 6 ml, you have to multiply it by 2. Okay, yung results mo. Okay? Kasi sabi nga natin, when there's too little volume, okay, it's equivalent to a fewer formed element. So we do correction. Okay? So in laboratories, you can check that doon sa kanilang SOP, Standard Operating Procedure for Urinalysis. Okay? So next, we have centrifugation. Okay? So for the centrifugation, we standardize the speed, okay, and the time of centrifugation. It's usually at 5 minutes, guys, okay, for at 400 RCF. So we use your relative centrifugal force instead of your revolutions per minute kasi that's to correct now for the variations in your centrifuge head's diameter. Okay? So guys, no, during centrifugation, ano ulit yung tatandaan natin? Dapat nakakap, okay, yung ating urine. Okay? Meron siyang takip yung specimen cap para maiwasan nating mabuhos o kaya kapag open natin, di ba, nung centrifuge natin, malanghap natin, okay, kung ano man lang, okay, yung elemento na nandoon. Okay? So, dapat nakatakip. Okay? And then, do not break the centrifuge. Anong ibig sabihin? Minsan, pag nagmamadali tayo, di ba, so, umikot-ikot yung centrifuge, tapos tumigil na siya, di ba, hindi naman kagad mag-stop yun. May konting paikot pa yun hanggang tumigil siya. So minsan yung mga technologies, pagka nagmamadali sila, ang ginagawa nila, pipindutin nila yung gitna ng centrifuge para tumigil na siya sa pag-ikot. Okay? Siguro pinaikot-ikot siya, ayaw niya na, gusto niya nang i-break. Okay? So kaya ang gagawin niya, pinindot niya yung gitna, okay, para tumigil na. Okay? So sabi niya, do not, okay, break the centrifuge. Bakit? Kasi it will cause now disruption of your sediments. Okay? So pwedeng masira yung mga formed elements natin, and of course, syempre, yung ating centrifuge, pag panay-panay, okay, yung gawa natin na ganun. Okay? So, sabi niya again, no, we make sure, okay, that all our specimens, okay, should be cup. So, saan na ba yun? Okay. So next, we have our post-centrifuge sediment. So ading, pagkatapos di ba natin na nag-centrifuge, okay, ang gagawin natin is to pipette, okay, yung ating how do you call this one, yung ating sediment. Okay, but in some laboratories, lalong-lalo na nga yung walang mga commercialized systems like your COFA, ang ginagawa lang natin ading, we just pour off the urine. Okay, tapos yung sediment, pinopor lang natin din siya dun sa slide. But for, for laboratories na merong mga commercialized systems, okay, they aspirate, okay, the sediment. Okay, so next, we have what we call the concentration factor. So ano yung concentration factor, ading? So your concentration factor will tell us, okay, the probability of detecting low quantities, okay, of formed elements. Okay? So like for example, paano natin compute siya? Volume of urine centrifuge over the sediment volume. So for example, adding, if the volume of the urine is 12 ml, and the sediment volume is 0.4. for example, or 0.5 for example, ml, diba that will give you 24, okay? A concentration factor of 24. Ibig sabihin, malaki yung chance na makadetect tayo ng mga low quantities, okay, of formed elements, okay? Or how you call this one? There's a big chance, okay, for us to detect now formed elements that are in low quantity, okay, doon sa urine natin, okay? So again, sabi niya, we should aspirate rather than pour of urine. So gumamit tayo ng pipette. So syempre ang nire-recommend po ng ating libro is yung ideal, okay, technique natin, and that's through the use of your commercialized systems. But of course, sometimes no, syempre we have to consider resources in the Philippines, lalo na sa mga ano natin, mga small scale laboratories, mga ganyan, they do not have naman, okay, the standardized commercial systems. So ang ginagawa ng mga technologies, pagka-pour nila ng urine, bubuhos lang din nila yung sediment. Okay, so may chance actually na matira yung iba, okay, na sediments doon sa tube natin. Okay, na hindi natin siya equally na madidistribute doon sa slide, unlike when we aspirate it. Okay, so next, so mix sediment gently and not vigorously. Kailan natin ito i-mix lang ulit? Pag natanggal na natin yung urine at naiwalay na natin yung sediment, tsaka lang ulit tayo mag-mix. Hindi yung hindi mo pa natanggal kasi walang kwenta yung centrifugation mo. Tapos shinake mo lang din, anya garod pa, centrifuge ka ulit okay? So that's the post-centrifugation sediment, okay? So next, we have the volume of sediment examined. Sabi niya, no, we have to be very consistent. Okay, so from one lab to another, pwede tayong magkakaiba, pero within, okay, the laboratory, okay, dapat pare-pareho kayo. Okay? Pero minsan, sabi ko nga sa inyo, kaya nga tinasawag siyang least standardized, kasi like for example, sa mga labs nga na walang commercial systems, hindi na mine-measure. Okay, pwedeng hindi nagiging consistent yung volume ng sediment kasi they just make, pour the urine, then tinataktak lang nila, okay, yung tube dun sa slide. Siguro nakakita na kayo kung paano nila ginagawa dun sa mga ano nyo noon, immersion nyo, okay? So, again, for us to be consistent, napakaganda if we have commercial systems, okay? If we really want to be consistent dun sa amount or volume of sediment na ine-examine natin. So we have commercial systems like your COVA, okay? Kasi nakokontrol natin kung ilan yung amount ng sediment na nakukuha natin for examination. Other than that, even no, the area of testing kontrolado din kasi yung ginagamit nating slide are special slides with grids, okay? Unlike dun sa typical manual UA, gumagamit tayo nung mga typical or normal slides na ginagamit natin. Okay? So, hindi natin talaga na measure kung ilan yung volume ng sediment. So, it's not standard. Okay? So, we also have the glass slide method. Okay? For you, for example, na walang mga commercial systems, you can be consistent sa volume by using your pipette. So you get approximately 20 microliters, okay? And then you put it in the slide and then after that, cover it by a 22 by 22 glass cover slip. Okay? So guys, no, the urine, okay, under the cover slip should not overflow. Okay? Wag dapat siya yung asin naman sobrang dami mong nilagay, tipong lumulutang na yung cover slip mo. Pag nangyari kasi yon, pwedeng pati yung lens mo mababasa. Okay? Lalo na kung mali ka ng pagtaas, okay, nung objective mo. Okay? Ng stage mo kakusana. Okay? So sabi niya guys, no, do not overflow your cover slip. Okay? And you also have to take note when examining, okay, yung mga urine sediment constituents natin, tignan po natin doon sa mga sites. So for example, ito yung slide mo adding, di ba? I-check natin, okay, dito sa mga pagpaligid-ligid niya. Kasi for heavier elements, halimbawa yung mga casts natin, na spread sila towards, okay, dun sa mga edges natin. So, pwedeng di mo sila makita dito sa gitna at doon mo sila makikita sa mga gilid-gilid. Okay, so you have to scan, okay, kahit yung gilid, okay, nung ating cover slip. Okay? So, next. Okay. So next, we have examination of your sediments. So sabi niya, again, we have to be very consistent in the examination. So again, sabi ko, within the lab, dapat pare-pareho kayo. Okay? Kung para sa'yo, ito yung RTE. Para sa'yo, ito ang hyalin cas. Dapat pare-pareho kayo ng kasama mo. Okay? Hindi pwede magkakaiba. Okay? Or for example, if we're counting 10 low power fields and 10 high power fields, dapat ganun din yung mga kasama mo. Hindi yung, kaya't ko 5 lang o kaya 2 lang. 'Di ba? Walang ganun. Okay? So, dapat same kayo. Pwede magkaiba kayo dun sa ibang lab kasi they are using different protocols, pero dapat within, okay, the lab na kung saan ka nagtatrabaho, pare-pareho kayo. Okay? That's to make your results more standardized. Okay? So, next, when examining, okay, yung urine sediments natin adding, we examine them under your low power objective. Okay? So, alimbawa, yung mga cast natin. Okay? Or of course, when we want to see the general composition of the urine. Pagtingin pa lang natin sa low power objective adding, makikita na natin if the turbidity corresponds, okay, with the amount of material that we can see under the microscope. Pag sobrang turbid yan, even okay, in low power objective, kitang-kita mo sobrang dumi niya. Sobrang dami mong makikita. Okay? So again, scan the edges for casts with the glass slide method. Okay? Bakit nga ulit? Kasi si cast mo, mabigat siya. Andun siya, maaaring napupunta siya dun sa gilid-gilid nung iyong cover slip. Okay? So how about your high power, okay, objective? Yung high power objective natin adding, we use this to determine now presence of your white blood cells, your red blood cells, your bacteria. Okay, mga ganyan. Okay? But of course, for cast, sabi natin, na-view na natin sila under low power, pero hindi natin sila kayang i-identify kung sila ba ay RBC cast, kung sila ba ay bacterial cast, okay? So, kailangan i-switch natin, okay, yung objective natin to high power objective para makita natin kung anong klaseng cast siya. Kasi we have to identify, okay, kung anong cast ba yung nakita natin. Okay? You know, in the identification of cast, maglaking tulong din yung nakikita natin sa paligid niya. So if for example, sabi mo, red blood cell kasi yan. Ngayon, mawamot makita, muray may isang red blood cell, baka hindi naman nga kasi red blood cell kasi yan. Baka nagkakamali ka ng identification. Okay, so yun yung isang hint natin, okay, in the identification, okay, of our casts. Okay, so for the initial focusing adding, tatandaan natin saan muna tayo. Di ba sa basic microscopy, alam nyo to, ang unang-una natin gagawin is mag-view sa low power. Bakit sa low power? Hindi pwede ba na kaagad sa high power? Or for example, when we're viewing siguro a peripheral blood smear, hindi ba pwedeng OIO kaagad? Hindi, baka mabasag mo mamaya yung lens mo. So sa low power ka muna, i-focus mo muna siya. And when you're using low power objective, anong tatandaan mo? Di ba dapat reduce ang light? Di ba? Pagka higher yung objective mo, mas taasan mo yung intensity ng ilaw mo. Okay? So if again, initial focusing is at low power objective with reduced light. Bakit importante to? Kasi adding, you have to take note, yung specimen mo ay unstained. Okay? And the form elements, they have very low refractive indices. Okay? Ibig sabihin, pag view mo sila under your low power, halos hindi mo sila makita. Okay? That's why you have to reduce the light. Okay? So, sabi niya, and of course, when focusing, okay, we try to look, okay, dun sa presence ng squamous epithelial. Siya yung unang-una natin madalas nakikita. So pag nakakita na tayo ng squamous epithelial cell, ay, nasa focus na ako. Okay? So not artifacts. Bakit hindi artifacts? Bakit? For example, sa low power, hindi mo pa napihit yung iyong fine adjustment knob. Nakakita ka ngayon ng air bubbles. So pag nakakita ka nyon, it's very refractile, very visible even under reduced light. So, wala pa ako, malayo pa ako sa focus. So I have to, make tawag dito adjustment using my fine adjustment knob, okay, para mapunta ka dun sa focus. So lagi ang ating tawag dito, ang ating hinahanap, okay, yung ating squamous epithelial cell, kung may present na squamous epithelial cell, para sa ganun madali sa atin, okay, malaman kung nandun na ba tayo sa right plane. Okay, so use your fine adjustment continuously for best view. Okay? So again, yung initial focusing natin sa low power objective, okay, with reduced light. Ma'am, kunwari nakita ko na nga siya, ma'am, sa low power objective at nakakita ko ng CAS, ma'am, but I need to identify anong klase siyang CAS. O di shift mo sa high power objective. And after that, you also have to what? 'Di ba? Dagdagan mo yung amount ng light mo. Kasi kapag higher yung objective mo at mababa yung light mo, medyo mahirap lalong makita yon. So, taasan mo. Okay? So, that's examination, okay, of your sediment. So, next. Okay, so we have here, artifact interference, okay, in the microscopic exam of urine. So we have here yung large pollen grain ninyo. So adding itong large pollen grain po na ito, kamukha niya din yung air bubbles ninyo. Parang ganito siya. It's just that here, kung makikita nyo sa pollen grain, parang may mga concentrics or may mga circle sa loob niya. Okay? So this is very, kung makikita nyo, ma-observe nyo yung sides niya, guys, it's highly refractile. Ganito din yung itsura po nung air bubbles ninyo. It's just that medyo clear lang lalo, or I mean plain yung loob niya. Ito kasi kita mo may mga may mga parang bilog-bilog pa siya dun sa loob niya. Okay, so this is a large pollen grain. So it's a contaminant. Okay? So pag nakakita ka ng ganyang kalaki, ibig sabihin yan, ading, wala ka pa sa right plane of focus. Okay? So kailangan mo pang pihitin na yung iyong fine adjustment knob. Okay? So no usual sediment elements in view, okay, when you see these, okay, artifacts. Okay? So grain is in a different liquid plane than the urine constituents due to its larger size. Okay? So, ibig sabihin, maring nandun ka pa lang sa surface, okay, nung iyong cover slip. Okay? Kaya pihit mo pa yung iyong fine adjustment para ma-focus mo ng mabuti, okay, dun sa actual plane, okay, for your urine. Okay? So next, we have microscopic reporting. So adding, just like doon sa volume ng ating sediment, okay, yung ating microscopic reporting should be consistent within laboratory. Okay? So, example, for the semi-quantitative grading or reporting of form elements, halimbawa, adding yung squamous cells natin, yung mucus natin, we grade them as rare, few, moderate, many. Or pwede namang using your 1+, 2+, 3+ reporting. Okay? So forecast, we usually, okay, report it average per low power field. Pero you have to take note, that's just for the quantitation. For the identification, saan natin gagawin? It's not in the low power field. It should be sa high power field. Okay? And then for RBCs and WBCs, we have them at average per high power field. So high power field yung gagamitin natin. And for epithelial cells, like your epithelial cells and your crystals, okay, we use semi-quantitative terms. Ano yung mga yon? We have rare, few, moderate, many. Okay? So guys, please check later yung sa book ninyo. Meron po tayo nung table na to, yung manner of reporting nung different form elements. Okay? So next, okay, so next we have sediment stains. So ading sabi natin kanina, napakahirap, okay, i-view ng mga form elements natin kasi they have no low refractive indices, okay? So lalong-lalo na when you were using bright field microscope at sobrang tas ng ilaw mo, halos di mo na sila makita, parang mga mumulang sila dun sa field mo, okay? So sometimes, okay, to better, okay, the visualization of these form elements, we can use stains, okay? Example are your supravital stains. So halimbawa, yung supravital stains, where we combine your crystal violet and your safranin O, that's your Sternheimer-Malbin, okay, stain. Sira kasi yung keyboard ko, guys, yung letter L niya nasira. So nasa book ninyo to, your Sternheimer-Malbin stain, okay? So we can use that to stain yung ating urine sediments. So anong ginagawa niya? Okay, it increase now the refractive index, okay? It stains the nuclei, especially for example, for your white blood cells, okay, mga ganon. Even the cytoplasm and the inclusions, okay? Other examples of systems that use this supravital stains, we have your SEDI stain and then yung COVA stain ninyo sa COVA commercial system. Okay? So what else? Adding other than your Sternheimer Malbin, okay, stain, we can also use stains like your toluidine blue. So yung toluidine blue, guys, we can use that to differentiate now yung WBC ninyo at saka yung renal tubular epithelial cells. So nasa book nyo lahat yun, guys, okay? And then what else? We can also use your acetic acid. Di ba maalala nyo to, guys, dun sa may physical examination of urine? Di ba, like for example, pag sobrang dami mong red cell na nakita at halos di mo na makita yung ibang mga formed elements, anong gagawin natin? Ire-report muna natin yung red blood cell. Lalagay mo TNTC or too many to count. Okay? O depende dun sa protocol, okay, nung lab kung paano nyo ire-report yung TNTC, okay, value. Okay? And then after that, you have to add acetic acid. Okay? So, anong gagawin ni acetic acid? Ilalize niya ngayon yung mga red blood cells mo para naman makita mo yung ibang mga formed elements. And other than lysing your red blood cell, it will also enhance, okay, the nuclei of your WBC. Eban, bakit kailangan pa nating enhance yung nuclei ng WBC natin? Kasi minsan yung WBC natin na pagkakamalian natin sila dun sa mga ibang mga form elements like your renal tubular epithelial cells. So kung i-enhance ni acetic acid adding, yung WBC nuclei natin ay ma-appreciate natin yung kanyang multi-lobe nuclei, di ba? For example, for neutrophils, makikita natin yung polymorphonuclear appearance, okay, di ba? So, which is not present dun sa renal tubular epithelial cells ninyo kasi kitang-kita mo lang, okay, na meron lang siyang circular or single nuclei. Unlike in your WBC na pwedeng bilobe, okay, yung dating niya. Okay? So next, okay, so we have here the different stains for our sediments. We have your lipid stains, okay? Adding yung pinaka-common for urine is your oil red O and your Sudan 3. So adding, these are your lipid stains, and ano yung principle ng staining nila? It's based on their solubility sa mga lipids. So kaya nila na-stain daw yung mga lipid natin, guys, kasi they're soluble to fats or lipids. Okay? So that enables them to to stain yung mga lipids natin. Okay? So guys, tatandaan nyo, when we're using oil red O and Sudan 3, we use them to identify now your triglycerides and your neutral fats. Bakit? Si triglycerides adding at saka si neutral fats, pag in-stain po natin sila with your oil red O and Sudan 3, ang kulay po nila ay orange red. Okay? Ano ngayon, ma'am? Okay? Kasi nga, si cholesterol mo, pag in-stain mo with your oil red O and Sudan 3, wala po siyang kulay. Okay? So, ma'am, paano ko mako-confirm? For example, ma'am, kung talaga nga ba siya ay si cholesterol. So, we can use your polarizing microscope. Okay, when there is presence of cholesterol, pwedeng nag-stain ka ng oil red O and Sudan 3 at hindi siya na-stain. Pero pag gumamit ka ng polarizing microscope, okay, at nakakita ka ng Maltese cross formation, okay, then that will tell you na, okay, yung lipid component dito or yung lipid content, for example, nitong RTE cell ko, ay cholesterol. Okay, kasi nag-stain na ako ng oil red O and Sudan 3. Walang orange-red color, so it's not triglyceride and neutral fat. So, after using polarizing microscopy, nakita mo na may Maltese cross formation. So, the content is cholesterol. Okay? So, next, we have also gram staining for identification of what? Your bacterial casts. Or for example, di ba, when we're performing culture and sensitivity sa urine adding ng pasyente natin, di ba, nag-gram stain tayo? So, ano na itutulong ng gram stain natin? It will give us an initial, okay, it will give us a clue. Ano kaya yung possible, okay, na nagkukos nung infection ng pasyente natin. So, if it's gram-positive ba siya na bacteria o gram-negative siya. Okay? So, alam nyo naman siguro, di ba, yung procedure natin for gram staining, we have your VIAS, di ba? So, in your gram staining, yung gram-positive microorganisms natin, it's purple, o kaya naman violet, di ba? O kaya in your gram-negative, anong kulay ng gram-negative? It's actually colorless. Nagiging pink lang siya okay, yung kulay niya kapag ka nag-counter stain na tayo with your safranin. Okay? So that's your gram staining. Okay? What else? We also have your Hansel stain. So biscuit lang, nagutom na ako. So we have your Hansel stain. Okay? So Adi, anong ginagamit natin? Si Hansel stain, we can use this to stain now your urinary eosinophils. Hindi kaman po na may eosinophils sa urine natin. But when they're present, okay, in large amount, that's approximately more than a percent, okay, of 100 to 500 cells, nagiging significant siya. Saan to natin nakikita, Ading? Doon sa mga patients natin with drug-induced allergy. Okay? So, pwedeng makakita tayo ng madaming eosinophils doon sa kanilang urine. And we can stain that eosinophil for identification using your Hansel stain. So, we use your methylene blue and your eosin Y. Okay? So next, we also have your Prussian blue. Okay? So adding, di ba maalala nyo before dun sa discussion natin, nung red urine. Especially for clear red urine. Okay? Di ba dun sa clear red urine natin, sabi natin pwedeng ang cause ay hemoglobinuria. So anong nangyari? Yung ating pasyente, for example, na nagkaroon, for example, ng, ano call this one? Hemolysis, okay? Dun sa circulation pa lang, for example, di ba napupunta dun sa urine, okay? Yung excess amount or excessive amount of hemoglobin na coming from the lyse red blood cells, okay? So adding, yung hemoglobin na yon, minsan hindi sila na-eliminate sa urine, nagstay po sila dun sa mga renal tubules natin as hemosiderin granules, okay? At yung hemosiderin granules na yun, guys, pag tumagal sila sa urine natin, like for example, yung pasyente merong renal failure, so sobrang tagal niya na doon sa ating tubules, sisirain niya yung kidney tubules. So these granules can cause now damage doon sa ating sa ating kidney tubules. Okay? So next, so those are the different stains, okay, for your urine. Okay? So adding, we have here naman different microscopy techniques. So hindi na natin to masyadong i-discuss kasi memorize nyo na ito siguro sa lahat ng topic na pinaka-memorize ninyo. Ito, okay, yung microscopy natin. So we have here the different microscopes that we can use to examine our urine and of course other body fluids. Okay? We have your bright field microscope. Siya po yung pinaka-common na ginagamit natin for routine urinalysis. Okay? And then we also have your phase contrast. Ano to? 'Di ba pinakamagandang gamitin especially dun sa mga unstained materials natin. Okay? We also have polarizing microscope and this is very beneficial, okay, in the identification now of your cholesterol, okay, in your oval fat bodies or yung RTE cells ninyo with lipids and of course sa crystals natin. Okay? What else? We also have dark field microscope, okay, that can aid us now in the detection of your Treponema pallidum, okay, or your syphilitic agent, okay? And then we have your fluorescence microscope, okay? And usually pag fluorescence microscope naman yan, guys, ginagamit natin usually yan sa immunology. Okay, di ba? Kung maalala nyo yung call this one, wait lang guys kasi may maingay. Okay, so and then of course for fluorescence microscope, so kung maalala nyo yung discussion natin dati sa immunohistochem, okay, dun sila madalas ginagamit. And of course your interference contrast microscope to provide now a 3D image, okay, of our material in view, okay. So next we have care of the microscope. So, bilisan na lang natin to guys. Kabisado nyo na siguro to. So, again, for the microscope, we have to carry it with 2 hands. Diba? Wag lang isang kamay. Baka mahulog natin. Masyadong mahal. Babayaran natin. Lalo kung nasa school tayo. Diba? So, always hold the microscope in a vertical position. Wag natin siyang pahigain. Okay? And clean the optical surfaces with a good quality lens tissue and commercial lens cleaner. Okay? Do not use your 10x and 40x objective with oil. Saan lang natin siya ginagamit? Siyempre, dun sa oil immersion objective lang natin. Okay? At saan tayo lagi mag-start? Dun sa lowest objective bago mag-shift sa higher objective. Okay? Clean the oil immersion lens after use. Okay? Always remove the slides with the low power objective. So, halimbawa, nag-view ka under your OIO. You have to remove the slide, or I mean, when you are to remove the slide na, i-shift mo yung objective mo sa low power objective. Bakit? Para hindi mo, or para maiwasan mo, okay, na matouch yung iyong lens sa high power, sa OIO at mabasag mo. Okay? O kaya mabasag yung mismong slide mo. Okay? Store the microscope with low power objective in position and the stage centered. So alam nyo naman siguro yan, di ba? In basic microscopy, pag natapos na po natin yung ating microscope na gagamitin, anong gagawin natin? Kunwari, ginamit natin yung OIO, i-shift natin siya sa LPO or your scanning objective, okay, yung lowest. Tapos, ibaba natin yung stage. Bakit? Para maiwasan po natin na kung nasa OIO yan at mataas yung stage mo, baka masira mo yung lens. Okay? So, care of the microscope. Okay? So, next, we have here the sediment constituents. Okay? So, many urines, okay, have just a rare epithelial cell. Kailan tayo nakakita ng madami? Sa mga babae halos. Okay? So, small amounts of constituents can be normal. So, sabi ko nga sa inyo kanina, hindi porke may nakita ka na isang WBC o isang RBC, ay, may sakit na yung pasyente. Hindi. If that's 0 to 2, 0 to 5, that's still normal. Okay? Can be normal or pathogenic based on the clinical picture. So for example, may nakita ka nga na konti lang na WBC ma'am or konting RBC ma'am yung nakita ko. Pero ma'am, ang dami kong nakitang WBC. Tapos ma'am, nakita ko nag-positive yung leukocyte esterase ko, nag-positive yung nitrite ko, nag-Dubai bacteria na. So when we can say, okay, na merong sakit yung pasyente natin. Okay? So, some constituents, okay, are easily distorted. Okay? Bakit? For example, di ba, pag highly alkaline yung urine natin, lalo na pag unpreserved yung urine natin, sabi natin, ading, ano nangyayari? Yung mga white blood cells natin, yung mga RBCs natin, naglalise sila, okay? Some becomes crenated, di ba? So, ano nangyayari? This will affect, okay, yung itsura ng mga constituents na yun or form elements, makikita natin under the microscope. So, kapag nagkaroon ng distortion ng mga form elements na to, ading, even, okay, yung mga medtech natin na experience na pinsan nami-miss nila. Okay? Kasi nagkaroon na ng distortion dun sa itsura nung mga form elements natin. Okay? So guys, no, we have here a picture showing to us no yung itsura po nung ating urine, okay, sediments. Okay? So ito yung madalas nakikita nating picture or microscopic image, okay, ng urine natin. Okay? So guys, kung makikita nyo, we have here presence of your red blood cells. Okay? Yan yung mga red blood cells ninyo ading. Okay? Atoy, dagitoy ka sa titsura da. Okay? Ito din mga red blood cells yan. Pero kung makikita nyo, yung iba dito, di ba, nakita nyo yung parang may mga spikes sila sa gilid. Yan yung mga crenated RBCs natin. Okay? So, ano nangyari? Maring yung specific gravity ng urine na to, napakataas. Okay? It's hyperstenuric. Okay? So, crenated. Okay, so we also have here your red blood cells also here. Okay, this is a COVA-stained, okay, image or an image of a COVA-stained material. Okay, tapos dito ading makikita nyo, we have here no, nagkukumpul-kumpul na mga red blood cells and may makikita ka dyan ading na mga yeast cell. Nakita nyo to? Meron siyang bilog na ganun, tas may maliit pa na ganun. Okay, so that's a yeast cell. Okay? So minsan nalilito ka, akala mo red cell siya. So look for how you call this one, field. Baka may iba ka pang makita na ganun. That confirms now na okay, that's budding yeast. Okay? So these are examples of the things that you can see under the microscope. Here naman, we can see here presence. Kung makikita nyo adding itong mga bilog dito, they're not your red blood cells, 'di ba? Nakikita nyo yung mga red blood cells natin, medyo faint yung itsura nila. Unlike tong mga bilog na to, napaka-dominant, okay? And napaka-definite nung borders nila, makakapal, okay? These are your oval fat bodies, okay? So adding yung mga oval fat bodies ninyo or yung mga lipid droplets natin, okay? Minsan akala natin mga red cells sila, okay? They're more highly refractile compared to your red cells. Yung mga red cell nyo dito, ganito yung sa unstained urine. Napaka-faint lang nila. Para silang mga mumulang. Okay? And minsan they appear like this, parang double-walled kako sana. Okay? Kasi because of the concavity, okay, dun sa gitna nila. Okay? So parang donut yung itsura nila. Okay? So, tignan natin, ano ba yung mga different form elements sa urine natin? Number 1, adding is yung inyong red blood cells. Okay? So, guys, saan po natin view yung mga red blood cells natin? We view them, okay, under your high power objective. Okay? And in most laboratories, we examine a minimum, okay, of 10 high power field. Okay? Hindi natin to ma-view sa low power, napakaliliit po nila. So, we have to switch sa high power objective natin. Okay? So adding, we have here a picture. Kung makikita nyo guys, ma-appreciate nyo yung donut appearance lalo dito sa red cell na to. Makikita mo ayan, double-walled siya. Okay? So bakit ma'am yung iba dark, yung iba light? Kasi magkakaiba sila ng plane. Okay? So iba-iba. Meron yung nasa top portion ng urine, meron yung medyo mas nasa pailalim, mga ganun. Kaya kala nyo, ma'am, ba't parang iba-iba yung tsura? It's not. Depende kung nasaan silang plane, okay, of view. Okay? So next, it's smooth, non-nucleated biconcave disc. Kaya kita mo yung donut appearance niya. Okay? So guys, so if you can see, if there is no presence of crenated red blood cell, we usually see that, okay, dun sa mga hyperstenuric urine. I-check mo yung specific gravity. If it's too high, yun yung reason kung bakit crenated siya. So may mga crenated RBCs tayo dito, maliliit lang kasi sila. Di natin masyadong ma-appreciate dito. Okay? And then we also have your ghost cells. Kapag ghost cells naman, very hollow, okay, yung itsura nila. Okay? So parang mga bilog sila na as in empty cell lang sila. And you have to check for the specific gravity. Makikita mo it's too low, it's hypostenuric. Okay? So again, in the identification of our red blood cells, anong gagamitin nating objective? Always yung ating high power objective. Okay? High power objective. So next, okay, so what are the different identification difficulties with RBCs? Number 1, minsan pagkakamalian po natin sila as your yeast cells. Okay? So paano natin malalaman, ma'am, na red cell ba yan? O baka naman po, how you call this one? Budding yeast. Okay? So titignan natin dito. So ito guys, red cell ito. Itong isa dito. Okay? Pero itong mga to, kung makikita nyo, it's, how you call this one? Your budding yeast is highly refractile compared, or more refractile, I should say, compared to that of your RBC. So kita mo, masyado siyang litaw compared dun sa mga red cells natin. Ito sila yung mga budding yeast natin. Okay? Sorry. So, anong gagawin po natin? We look for buds. Yung pinball appearance. Nakita nyo to? Yan. Para siya yung amoy bowling, di ba yung pinball? Parang ganyan yung itsura niya. Okay? So, ayan siya. May mga buds. Okay? So, those are your budding yeast. And saan natin to i-correlate? Doon sa chem exam result niya for glucose. Ang common nating makita to lalo sa mga female patients natin adding. Lalo na guys sa hospital, madalas sa mga old age female patients, yung mga babako na, okay, lalo na kunwari meron silang mga diabetes na meron tayong makikitang mga ganito, okay? Or kung wala man minsan, meron nga silang infection, okay? So, kailan natin masasabi na true infection yan, okay? kung yeast yan, for example, dapat meron tayong presence ng white blood cells. Okay? Kung walang white blood cells yan at meron kang mga yeast cells, ay baka contamination yon. Okay? So next, we have oil droplets. So just like yung air bubbles ninyo kanina, adding yung pollen grain ninyo, they're very refractile. Kitang-kita mo sila. Di ba nakita niyo yung red cell kanina, para silang mga mumu? Very faint lang yung itsura nila. But for your oil droplets and air bubbles, mas malalaki sila, mas malaki lalo na yung air bubbles mo at pollen grain mo. And very refractile at kitang-kita mo sila. Okay? At lalo for your artifacts like your air bubbles at saka yung iyong pollen grain, makikita mo pwedeng in a different plane. Example, hindi mo pa masyadong napihit yung fine adjustment mo. Akala mo nasa view ka na. So, puro ganun lang yung nakikita mo. So, ibig sabihin, those are your artifacts. Wala ka pa dun sa actual plane ng focus for your urine. Okay, what else? We also have starch, okay, which is highly refractile then, and when we use yung polarizing microscope ninyo, nagpo-polarize din siya. So, anong gagawin natin, ma'am? We try to check for reagent strip correlation. Okay, halimbawa, nagadumot ti red cells na, sabi natin. Okay? Tapos, in your, in your chem exam, negative naman siya. Okay? Kasi kahit malaysa na yung red cell mo, magpa-positive ka pa rin kasi ang dinedetect nun is hemoglobin naman. Okay? Bakit nagadungom awamot? Okay? So, baka hindi naman kasi red cell yung nakikita mo. Okay? So, you have to identify. Okay? So, for the budding yeast, ganito yung appearance niya, ading may mga buds. Or minsan, other than the budding, okay, yeast, makakita ka pa ng parang mga sanga-sanga. Okay? Yung mycelial form nung fungi natin. Okay? So, parang may mga, alam mo yun, yung sanga-sanga ng plants, okay, other than the budding yeast, andyan sila. So, that confirms na it's a yeast, okay, infection. Okay? And those are your budding yeast. Okay? So, what else? So, we have here a picture of air bubble. So, kung maalala nyo yung picture ng pollen grain kanina, ading, kamukhang-kamukha din siya ng air bubble. It's just that dun sa pollen grain, meron tayong concentrics dito. Okay? So, may mga laman siya sa loob. Okay? So, also we have the oil droplets. Okay? So, pwede yung oil droplet din na to, guys. Minsan, pag nagre-reuse tayo, di ba, ng mga slide natin or cover slip, pwedeng nakaroon ng contamination with the oil that we're using for OIO. So, pwedeng ganito yung appearance niya. Wala kang ibang makitang form elements kasi nasa top view ka pa lang. Okay? Wala ka pa dun sa actual plane of view. Okay? For your urine. Okay? So, next, tapos tandaan niyo guys, yung itsura nila ading mas malalaki compared dun sa mga actual red cell. Okay? So example nito ading sa LPO ito, napakalaki niya. So pwedeng contaminant to, not the actual one that we see in renal diseases. Okay? So kung makita niyo yung sobrang kaliliit dun sa mga yon, those are your red blood cells. Okay? Yung mga sobrang liliit na ganun. Okay? So, pwede natin silang i-view, okay, under your HPO. Ito kasi LPO pa lang yung view niya. Kita nyo, medyo maliit pa ng konti yung squamous. Pero pag nag-HPO kayo, lalaki ng konti yung mga red cell natin at mas lalaki yung squamous natin. Okay? Okay, so next, we also have what we call your dysmorphic RBCs, okay? Yung mga dysmorphic RBCs natin, they may vary in shape from the normal, okay? So parang abnormal yung kanilang shape, okay? So we can see them, okay, in your glomerular bleeding or in normal circumstances or in normal conditions like, for example, after a strenuous exercise. Okay? So, na makikita natin, minsan, we can see acanthocytic blebs. Yung mga red blood cells natin, may parang mga protrusions sila. Okay? So, pwedeng pathologic daw yung cause niyan or pwedeng normal. So, pwedeng due to strenuous exercise or due to glomerular bleeding. Okay? So guys, no, in for example, dun sa strenuous exercise nyo ading, di ba may mga acanthocytic red cells tayo or yung mga dysmorphic RBCs ninyo. So minsan, other than the presence of this red cell, nakakakita din tayo ng hyaline cast, okay, nung mga granular cast ninyo, and RBC cast. Pero again, normal yon, okay? Mawawala siya after rest, okay? So, it's different from your glomerular bleeding. So always we check, 'di ba? Of course the physician do check, okay, patient history, the signs and symptoms, mga ganyan. Okay? What else? We can also see presence of fragmented hypochromic cells. Okay? So like for example, pag in-stain natin siya, 'di ba sa hema nyo yung right stain, okay? Pale looking yung gitna niya. Sobrang pale, masyadong malaki yung pale area niya. Okay? So we can see that also in conditions like in glomerular bleeding or your strenuous exercise. Okay? So these considerations will aid now dun sa diagnosis ng pasyente natin. Again, the physician of course will not just base yung kanyang diagnosis dito sa mga nakita natin sa UA. Okay? Gagamitin niya din yung other how do you call this one? For example, the signs and symptoms, the history of the patient, mga ganun. Okay? So next, okay. So next we have here the clinical significance, okay, for our red blood cells. So ano yung normal value for red blood cell natin adding? It's 0 to 3 or 5 per high power field. Ibig sabihin, after examining 10 high power fields at nakakita lang tayo ng 0 to 3 range, then we can say, okay, that's what? Normal. Normal pa rin siya. Okay? But, for example, no, in patients, okay, with glomerular membrane damage, okay, in patients with vascular injury due to, for example, genitourinary tract infection or for example, yung UTI natin, pwedeng magkaroon tayo ng more than this number, okay, and that we can consider it significant. Okay? So tandaan nyo, the number of cells or of your red cells is equal to the extent of damage, lalong-lalo na dun sa ating glomerulus. Di ba sabi natin, this is the glomerulus, okay, yun yung PCT ninyo. Di ba, we have here your afferent arteriole and then your efferent. Yung mga red blood cells natin normally are propelled back dun sa circulation due to the structure din nitong glomerular basement membrane natin. Meron siya na tinatawag na shield of negativity, ganyan. Okay? So, but because of the damage in the basement membrane, di ba, merong parang ang dating kasi nito is parang siya yung nagsasala. Okay? So, dahil sobrang kaliliit, lumuwang na, okay, yung mga spaces, okay, dito sa membrane natin, nasasala sila palabas dun sa circulation natin. So nakikita natin yan sa mga pasyente na damage yung glomerulus. Okay, lalong-lalo na din sa mga pasyenteng merong renal failure. Okay, so next, we have here your macroscopic versus your microscopic hematuria. Ading ano na nga ulit yon, okay? So tatandaan natin, for your macroscopic hematuria, anong ibig sabihin ng macroscopic hematuria? Visible na visible, okay? Na red yung kulay ng urine natin. May dugo. Kitang-kita mo dun sa physical appearance ng urine na merong dugo siya. And this is very common saan? Sa glomerular membrane damage natin or vascular injury dun sa genitourinary tract natin. Okay? How about in your microscopic hematuria? So your microscopic hematuria, madalas po natin itong makita adding dun sa conditions like for example, renal calculi. Okay? O kaya yung mga pasyente natin na merong cancer. Okay? So for example, patients with kidney cancer, mga ganun. Okay? Or tumor in the kidneys. So we can see presence, okay, of microscopic hematuria. Anong ibig sabihin ng microscopic hematuria? Physically, mukhang clear yung urine ng pasyente, pero pag tinignan mo under the microscope, ay may significant amount ng red blood cells. Okay? So again, for cloudy red urine, anong meron doon? Ibig sabihin may mga intact red cells. Okay? So advanced disease, trauma, acute infection, and coagulation disorders. For clear urine naman, example in early glomerular diseases, malignancy, strenuous exercise, and renal calculi formation. So ang tinutukoy po nitong nasa baba adding, this is your microscopic hematuria. Okay? This one here, the cloudy red, okay, example dun sa sobrang damage na yung glomerular membrane natin, okay, or in advanced renal failure, mga ganyan, meron tayong macroscopic hematuria. Red na red mo talaga makita yung urine mo. Okay? So even without looking sa microscope, alam mo na madami kang makikita na mga red cell. Okay? So next, we have our white blood cells. Okay? So guys, no, yung sa mga white blood cells po natin, ang madalas makita natin sa urine ay yung ating neutrophil. And just like your red blood cell, ang ating mga white blood cells, we should view them what? Under your high power objective. Okay? So guys, maalala nyo kanina, di ba may mga variations tayo dun sa itsura ng inyong red cell. Pwede silang crenated or yung mga ghost cell. Depende dun sa specific gravity ng ating urine. For white blood cells, we also have what we call your glitter cells. Bakit glitter? Kasi pag tinignan mo sila under the microscope, nag-glitter sila, glittery sila. Okay, bakit? This is usually seen in patients with hypotonic urine. Okay? So, nung nangyari, nagkakaroon tayo ng Brownian movement ng mga granules doon sa loob ng ating white blood cells, kaya nagkakaroon ng sparkling effect. Okay? So, pwede natin din po silang i-identify using now a stain where they're stained pale blue. Okay, like for example, with your methylene blue, pwede natin silang makita. Okay, but your glitter cells, okay, they're non-pathologic. Okay, so pwedeng normal lang na andyan sila, okay, dun sa ating urine. Okay, and again, anong cause? Due to the Brownian movement of granules, okay, inside the neutrophil, okay, or inside the white blood cells present in an hypotonic urine. Okay? So guys, we can see here a picture of our white blood cells. So titignan natin, sobrang dami niya ading. Kita nyo, yung mga red cells natin kanina, mas maliliit sila. Wait. Mas maliit sila guys. Okay, 'di ba ang mga red cells natin about 7 micrometer, itong mga white blood cells nyo mas malalaki sila. Mga 12 ganun sila to 15 micrometer. Okay? Ito mas malaki sila. Tapos ma-appreciate nyo guys, 'di ba yung white blood cells natin, other than seeing them na double walled, malinis yung loob nila. For your white blood cells, kita mo ang dumi ng loob nila, granular yung loob. At makikita mo dito ading yung kanilang nucleus. Okay? So yung iba may parang impression na dalawa yung nucleus niya, like this one. Kasi bilobe nga, di ba, hypersegmented, okay, yung kanyang nucleus. Okay? So, next, ito naman ading is a white blood cell, okay, na present, okay, in urine with your acetic acid. Di ba maalala nyo sabi natin, we use your acetic acid to what? To enhance the nuclei of our white blood cells. At ginagamit natin si acetic acid pagka sobrang dami ng red blood cells na halos din na natin makita kung ano pa yung mga ibang significant form elements na present dun sa urine natin. So gagamitin natin siya to lyse, okay, yung ating red blood cells after reporting, okay, for red blood cells. Okay? So then, makikita mo then malalize yung mga red blood cells mo, and then makikita mo yung ma-appreciate mo lalo yung enhanced nucleus ng ating white blood cells. So kita natin dito yung bilobe, okay, nucleus niya. Okay? Parang may mata siya. Ayan, kitang-kita mo dito. Okay? Ayan. Okay? So those are your white blood cells. Okay? So next, okay, we have naman yung mga eosinophils ninyo. Saan ulit ito nakikita? So nabanggit natin last time, di ba? Dun sa Hansel stain natin. So we use your Hansel stain to stain your eosinophils, okay, that are usually considered significant when present in a population of about greater than 1% of 100 to 500 cells. Okay? So for example, you counted 100 cells at in that 100 cells, nakakita ka ng at least 2 okay, eosinophils, then we can consider that result significant. Saan natin nakikita? Example, in drug-induced interstitial nephritis or renal transplant rejection. Okay? So kung makikita nyo sila guys, Hansel stain siya, makikita mo yung kanyang granules. Yan no? Yung parang mga violet color granules dyan. Okay? So we can consider that significant, assuming that the cells counted are of 100 cells. Okay? So it's more than 1%, okay, of the 100. Okay? So next, we also have our mononuclear cells. So for under your mononuclear cells adding, we have your lymphocytes, yung monocytes natin, your macrophages, and your histocytes or your tissue macrophages. Okay? So adding, anong gagawin natin with your mononuclear cells? Adding, hindi kasi katulad, okay, nung ating nagaminaganan nung ating mga neutrophil. Di ba yung mga neutrophil nyo kanina, ading kita nyo bilobe sila. Meron kang makikitang mga fragments ng nuclei. Pero with your mononuclear cells, di ba, single nuclei sila, kita mo na bilog. Okay? And that's very important, and that's why it's very important for us to differentiate it from your renal tubular epithelial cells. Adding yung renal tubular epithelial cells kasi natin, they're significant. Okay? Pag nakita natin sila, like for example, when we can see them more than 2 of that RTE in the urine, significant yon. Okay? That may indicate what? Problems dun sa renal tubules ng ating pasyente. Okay? So, kailangan natin siyang i-differentiate from your mononuclear. Kasi baka mamaya akala natin may renal tubular damage yung kasing pasyente, ng mononuclear cells gayam, aday nakita tayo ang gayam nga renal tubular epithelial. Okay? So, we have to differentiate. Okay? And also check other results. Okay? So, di ba when we were talking about renal tubular epithelial damage, pwede din tayo makakita ng mga casts, mga ganyan. Kung puro mga mononuclear cells lang naman at walang mga casts, so malamang sa malamang baka nga mononuclear cells yung nakikita natin. Okay? So, lymphocytes may resemble RBCs, okay, seen in early transplant rejection, okay, and may need to refer, okay, to cytodiagnostic testing. So adding yung cytodiagnostic testing natin, it's not the work na nung sa clinical microscopy lab, it's usually under your anatomic lab. So sa histopath na to madalas, okay, pina-perform. Hinihiwalay kasi natin, okay? So next, what's the clinical significance, okay, of seeing now WBCs, okay, doon sa ating urine, okay? So again, kapag yung WBC count natin is less than 5 per high power field, lalong-lalo na sa mga babae, we can still consider that normal. Higher than that, okay, pwedeng yung pasyente natin ay mayroong infection, okay? So, your WBCs may enter through glomerulus. Guys, mayroon naka-open yung tawag dito. Naka-open ng mic, medyo na ako. Okay. So, sabi niya, it may enter through glomerulus or trauma, but also may be amoeboid. Natanggal ko. Labas na anak. Okay? So, your WBC, okay, may enter through glomerulus or trauma. Okay? So, adding kapag for example, sa glomerular bleeding, di ba, together with your red blood cells, may makikita kang mga white blood cells din. Okay? So, minsan, pag gano'n ang nangyari, yung appearance nila, syempre, bilog sila. Pero like for example, for patients na merong infection, halimbawa, meron silang cystitis or pyelonephritis, minsan amoeboid yung itsura nila. Lalo-lalo na yung mga mononuclear cells natin, di ba? Yung mga phagocytic cells natin, yung macrophages natin. Bakit amoeboid? Kasi di ba during infection, they migrate sa circulation papunta dun sa tissue natin. So minsan natatanggal sila dun sa kinakabitan ng tissue, na wash out sila papunta sa urine. So amoeboid yung itsura nila. Okay? So your WBCs, okay, when they're increased, okay, in the urine, we term that your pyuria. Okay, saan tayo nakakakita adding ng pyuria? Okay, in infections like your cystitis is an infection of the bladder, okay, that's lower UTI, okay, and then we also have pyelonephritis, the one involving the kidneys, okay, that's your upper UTI, okay, we also have in prostatitis, okay, prostatic infection, and your infection, okay, sa urethra or your urethritis. Okay, what else? Other causes, we have, for example, in your glomerulonephritis. So, together with, saan? Di ba, may mga kasama siyang mga red blood cells. So, hindi lang white blood cells yung may makikita mo dyan. May mga red blood cells din. Okay? What else? We also have in SLE or your lupus erythematosus, interstitial nephritis, and in tumors. Okay? So, adding, mamaya makikita natin, ano ba, ma'am, yung difference between your upper UTI and your lower UTI? Makikita natin siya mamaya dun sa gaminaganan sa cast natin. Okay, so tignan natin mamaya. Okay? So again, for WBCs, madalas natin saan sila nakikitang condition? Sa infection, like cystitis, pyelonephritis, prostatitis, urethritis. O kaya naman in non-infectious conditions like your glomerulonephritis, your lupus, your interstitial nephritis, and in tumor. Okay? So next, okay, so next we have epithelial cells, okay? So adding for your epithelial cells, okay, we have three types. Wait lang guys, kasi ayusin ko lang yung upuan na. Okay, so we have three types of epithelial cells. We have yung squamous natin na usually po not significant, okay? We also have your transitional or yung tinatawag nating urothelial, okay? Adding yung urothelial cells natin, meron tayong iba't ibang uri, okay? Meron tayong iba-ibang shape ng transitional natin. Pwede siyang spherical, pwede siyang caudate, o pwede po siyang cuboidal, okay? And then we also have your renal tubular epithelial cells. So yung renal tubular epithelial cells natin, just like your transitional or your urothelial cells, may iba-iba din siyang shape. Pwede siyang columnar, pwede po siyang bilog, o kaya pwede naman siyang cuboidal. Okay? So ano yun? Depende kasi kung saan siya galing. Okay? So classifications, okay, we have for squamous. Saan natin ito madalas nakikita or they're derived from where? From the vagina of female patients or from the male and female urethra. At pag nakita po natin sila, they're usually not significant. Okay? So dito sa picture na ito, ading, okay, makikita natin, ito parang mga sunny side up eggs. Ito, yan, yung mga squamous epithelial cells ninyo. Okay? And then we also have your transitional or your urothelial. Saan to nanggaling? Doon sa bladder natin, urinary bladder, in the renal pelvis, and your calyces. Okay? Or we call them your urothelial cells. So we have here some itsura, okay, of your transitional. We have the caudate, okay? So yung adding yung caudate, okay, form ng transitional, parang may buntot siya. Okay, makikita nyo dyan. Okay? And pero hindi lang ito ha, yung itsura ng transitional mo, meron ding bilog. Okay? Meron din siyang polyhedral. Okay? And then we also have your renal tubular epithelial cells. Saan po sila galing? Sa mga renal tubules natin. So katulad nung transitional or urothelial cells ninyo, adding, yung renal tubular epithelial cells ninyo, may iba-iba din po silang hugis. Depende kung saang renal tubule sila galing. Okay? So, tignan natin. Okay, this one adding naman is an RTE. Di ba nakamukha niya yung white blood cell, pero tatandaan ninyo, mas malaki po siya sa white blood cell ninyo. Though, these are your white blood cells. Okay, yan, yung mga white blood cells nyo. Ito, bilog na bilog at mas malaki, at makikita nyo adding may nucleus siya that is eccentrically located, nasa medyo gilid. Okay, that's your RTE. So, ma'am, ano po ba yung importance of knowing yung location ng ating nucleus? Because meron tayo pong round na RTE, meron din tayong bilog na transitional epithelial cell. So pareho sila. Saan mo sila na differentiate? Dun sa kanilang nucleus. Okay? Yung nucleus po ng transitional epithelial cells natin, centrally located. While for your RTE, they're eccentric. Okay? So those are examples. So meron din tayo mga crystals dito. We have your calcium oxalate crystals or yung CaOx ninyo. Okay? So next. Okay. So first we have your squamous epithelial cells. Okay? So adding, it's the largest cell in the urine. Kaya nga 'di ba sabi natin ginagamit natin siya when we're doing initial focusing. So kapag ka nakita na natin siya, ay nasa focus na ako ng urine. Okay? So ang reporting po natin semi-quantitative, it's rare, few, moderate, many. Okay? So, i-check mo sa SOP, okay, nung lab mo, ano yung rare? Ilan yung count? Anong average yung few? Yung moderate o yung many? Okay? So, guys, no, depending on the lab, pwedeng ang reporting nila is per low power field or per high power field. But in most lab, it's usually at per low power field kasi malalaki po ito. Okay? So again, they're normal, they are actually from the normal sloughing, okay, of epithelial cells coming from the vagina or the urethra. Okay? So anong gagawin natin para maiwasan natin yung too much amount of these squamous cells? We collect midstream clean catch. Lalo kapag ka babae yung iyong pasyente. Okay? So next, okay, so next we have the clue cells. Kailan ading nagiging pathologically significant, okay? Or I mean, significant, okay, yung ating squamous cells, okay? Kapag siya ay isang clue cell, okay? Ano yung clue cell? These are actually your squamous epithelial cells, okay? Studded with your cocobacilli. So punong-puno siya ng cocobacilli, okay? May palamuti siya, puro cocobacilli, okay? So guys, no, that's this is very common, or this is actually a pathognomonic entity for your Gardnerella vaginalis infection. So in bacterial vaginosis, okay? So yung mga pasyente na merong bacterial vaginosis, okay, caused by your Gardnerella, makakakita tayo ng mga squamous epithelial cells nila studded, okay, with your Gardnerella cocobacilli. Okay, so covered yung kanyang surface, okay, with the cocobacilli. So that's a how do you call this one, that can be used now to give diagnosis sa pasyente natin. So pag nakita natin siya, okay, that patient no has bacterial vaginosis, so nangangati din siguro, okay? So meron siyang presence ng mga clue cells, okay? So next, okay, so next we have your transitional or your urothelial cells. Saan natin ulit to nakikita? From the term transitional, di ba, yung mga cells natin sa urinary bladder, okay, the renal calyces, okay, and pelvis. So we also call them your urothelial cells. Kasi di ba maalala nyo, ading, di ba nung naghisto kayo, you have there the transitional epithelium or yung tinatawag nyong urothelium. Kaya yung cells niya tinatawag ding urothelial cells. Okay? So we have three forms. Okay? We have the spherical. Spherical siya, ading, kasi sumupsup po siya ng madaming tubig coming from the bladder kaya naging bilog. Okay? So sa bladder madalas to nakikita. Okay? We also have the caudate. Okay? So yung caudate, they have a tail. Parang yung nakita nyo kanina, parang trichomonas actually yung tsura din niya. So gumanon siya. Tapos meron siyang nuclei. Okay? So caudate or polyhedral. So almost parang mag-square na yung tsura niya. So may madami siyang sides. Okay? So that's your polyhedral. Okay? Urothelial cells. So anong dapat nating gawin? Okay? Lalo na adding for the spherical, okay, transitional cells or urothelial cells, di ba minsan na pagkakamalan natin siyang renal tubular epithelial cell na bilog. Okay? Kasi magkamukha nga sila, pareho silang bilog. Pero paano natin ma-differentiate ito from your renal tubular epithelial, lalo na yung sphericals natin? We observe the nucleus. Kapag centrally located yung nucleus ng bilog na epithelial cell na yan, then that's a transitional cell or urothelial cell. If the nucleus is eccentric, it's circle or spherical, and the nucleus is eccentric, okay, or pushed to one side, okay, then that's your RTE or renal tubular epithelial cell. Okay? So your transitional cells, guys, no, sometimes we can see them in clumps and we term that as your syncytia. Okay? And this is very common sa mga pasyente na merong malignancy, like for example, bladder cancer, for example, or urinary bladder tumor, mga ganyan. Or in patients, no, that underwent catheterization. So again, for your transitional urothelial cells adding, pwedeng hindi siya significant. Okay? But when seen in large amount, pwedeng it may be caused by your malignancy or due to a malignancy. Okay? So adding, we have here, no, presence of your urothelial cell. Nakikita nyo yan, ading, para silang tukak. Char, okay. So guys, no, may parang bundot sila. So these are your caudate, okay, transitional urothelial cells. And we can see here naman a clump, okay, of your transitional epithelial cells. Ano nga ulit tawag natin dito? Syncytia. Okay, saan natin nakikita? Example sa malignancy involving the bladder, okay, or the urothelium, okay? O kaya naman among patients, okay, na catheter, okay? So next, wait lang guys ha, wait lang. Okay, so we have here your RTE cells, okay? So the size, okay, and shape, sabi niya, vary with renal tubular area. Okay, so kung makikita nyo dito, adding, naririnig nyo ba ako, guys?
Yes, ma'am.
Yes, ma'am.
So adding yung size and shape, sabi niya, may vary, okay, with renal tubular area. So kung columnar yan, okay, that RTE is from your proximal convoluted tubule. If it's round or oval, it's from the distal convoluted. And if it's cuboidal, it's coming from the collecting duct. Okay? So yung basis natin ng location niya is yung shape niya. Okay? So again, tatandaan nyo ito adding yung round or oval natin or the RTE coming from the distal convoluted tubule, minsan nakala natin sila ay mga urothelial cells. So anong gagamitin ulit natin? To identify kung ano nga siya, kung RTE ba siya or urothelial yung kanyang nucleus. If it's eccentric, then that's your RTE, okay, coming from your DCT, okay? So, presence of 3 or more cuboidal cells, we call these your renal fragments, okay? So, madalas tayo nakakakita adding ng clumps of RTE, okay? Lalo na sa mga cuboidal cells natin na RTE, not with your columnar and your round. Okay? So next, so ano yung clinical significance nito? So they're renal tubular epithelial cells. Ibig sabihin adding, sila po ay mga cells coming from our renal tubules. Okay? At na-slow sila from there, okay, pwedeng normal o pwede namang due to a condition. Like for example, when there's damage, okay, doon sa ating kidney tubules. Halimbawa, in patients no with hemolytic disorder, okay, 'di ba na-expose sabi natin yung mga tubules niya doon sa hemoglobin, 'di ba may hemoglobinuria, okay? So na-stay yung hemoglobin na matagal sa tubules, then there's also retention of urine or yung tinatawag nating urine stasis. So sobrang exposed ng urine tubules natin, yung renal tubules natin, na damage siya, okay? Because your hemoglobin is toxic dun sa tubules natin. And that leads now to the sloughing of these epithelial lining cells, okay, from the renal tubules, okay? So, first, we have your PCT cells or yung RTE cells ninyo from the proximal convoluted tubule. So, they are the largest, okay? So, they're larger than the RTEs coming from your collecting ducts and your DCT. Okay? So, ano yung shape ulit nung ating RTE coming from the proximal convoluted? It's columnar, convoluted, or rectangular. Kaya tinatawag din sila minsan na convoluted renal tubular epithelial cells. Okay? So, that's your PCT RTE cells. So, guys, no, ito po yung picture niya. And your PCT RTE, minsan, no, they resemble your, saan na ba yung, yan. Okay? Kamukha nila yung cast ninyo. Okay? CASTS. Okay? So, minsan kamukha nila yung cast natin. Okay? But, bakit? Kamukha nila yung anong cast nyo? Yung granular cast ninyo. Bakit? Kasi kung mapapansin ninyo, yung kanilang cytoplasm granular. But, paano natin nalaman na siya ay si RTE-PCT? Kasi, because of the presence of this eccentric nuclei. Kita nyo yung nuclei niya dito, adding. Okay? So, we notice now, okay, yung presence ng kanyang eccentric nuclei. Okay? So next, we have naman no, the DCT. So adding yung DCT or distal convoluted tubule cells or the RTE-DCT. Okay? It's round or oval shape. Sorry. So ano yon? 'Di ba yung round and oval shape, ito madalas yung napagkakamalan po nating urothelial cells natin kasi may bilog din, 'di ba, na urothelial cells natin. So paano natin malalaman kung siya ba okay ay si RTE o kaya siya ba ay si urothelial dun sa kanyang nucleus. Okay? Yung nuclei niya yung i-check natin. Okay? So guys, no, we have here no a picture, okay, of our distal convoluted tubule cell, yung RTE mo. Kung makikita mo eccentric yung kanyang nuclei. Okay, dito. Push siya sa isang side. Okay? And here, okay, we can see here no presence, okay, of our DCT RTE din. Okay? So it may resemble din yung ating WBCs. Diba? Kamukha niya yung WBC nyo, guys. Pero ano yung difference? Ito, white blood cell to, mas malaki po. Yung RTE ninyo, mas malaki siya. Okay? At yung WBC nyo, especially when we're using acetic acid, kitang-kita mo yung kanyang bilobe nuclei or fragmented nuclei. Or I mean, hypersegmented, I should say, na nuclei. But with your RTE, kita mo yung single lobe, okay, nuclei that is eccentrically located. Okay? So we observe the eccentrically placed nucleus to differentiate it from your spherical transitional. Okay? So saan tayo nagkakamali with your DCT cells? Okay? Or the renal tubular epithelial cells coming from your distal convoluted? Pwedeng akala natin minsan siya ay si transitional or urothelial cell o kaya naman WBC. Okay? Anong pinagkaiba niya with your WBC? Mas malaki siya. Okay? Other than that, makikita natin yung difference ng kanilang nucleus. Okay? How about yung difference niya kay transitional? Yung kanilang nucleus, okay, ay eccentric. Si transitional ay centrally located. Okay? Okay, so next we have our collecting duct RTEs. Okay, so these are your renal tubular epithelial cells na formed sa collecting duct natin. They're cuboidal and they're never round and at least one straight edge. Has at least one straight edge. So pwedeng ganyan yung itsura nila. Okay, so they have eccentric nucleus just like other RTEs. Okay, so guys, no, tatandaan natin for your collecting duct renal tubular epithelial cells, they usually form renal fragments na hindi natin nakikita dun sa naunang mga RTEs natin. Okay, yung inyong PCT and DCT. Ito, nagka-clamp sila. Okay, and they form large sheets. Okay, so we call these your renal fragments. Okay, so that's your RTEs or those are your RTEs. Okay, so what's the clinical significance? Pag nakakita tayo ng mga maraming renal tubular epithelial cells, okay, doon po sa ating urine, ano po yung ibig sabihin? Okay? So at kailan siya ba nagiging significant? It's when we see more than 2, okay, of RTE cells sa urine. Pag mas mataas sa dalawa yung bilang, then we can consider that clinically significant. Okay? So, anong ini-indicate nun? Pwedeng meron tayong tubular necrosis caused by what? Example, yung pasyente nga natin, di ba, nagkaroon siya ng glomerular bleeding. Okay? Or for example, the patient no has hemolytic disorder. Anong nangyari? Na-expose yung kanyang key tubules dun sa hemoglobin. Okay? No, so, nagkaroon ng damage dun sa tubules niya. Or for example, exposure to heavy metals, okay, or drug toxicity, for example. So they can cause now tubular necrosis, okay? Or other causes, we have your viral infections, pyelonephritis, or your upper UTI, transplant rejection, and salicylate poisoning. So pag sinabi natin tubular necrosis or tubular damage caused by infection or urinary tract infection, tandaan mo na it's always your payelo, hindi yung iyong cystitis or yung iyong lower. Okay? It's always upper. Kasi yung tubules mo, di ba, nandun mismo kidneys mo yon. Eh, di ba yung pyelonephritis, it's upper UTI involving the kidneys. Pag cystitis kasi yan, di ba, ito yung kidney mo, kunwari, o di ba ganyan siya. Bladder. Dito yung cystitis eh. So, hindi niya nakuha dyan. Okay? So, sa payelo, ito yung involved mismo. So, pwede siyang mag-cause ng tubular necrosis or tubular damage. Not with your cystitis or lower. Kasi nasa ilalim na yon, nasa baba. Okay? So, for the presence naman of single cuboidal cells, pwedeng makita natin no, in salicylate poisoning. Okay? So guys, no, you have to take note, itong mga renal tubular epithelial cells po natin na ito, pwede silang mag-absorb ng bilirubin. Kaya minsan yung itsura nila, yellowish yung kulay nila, like for example in viral hepatitis. O minsan meron silang mga hemosiderin granules or yung mga degraded hemoglobin natin. 'Di ba sabi ko nga kapag nagkaroon tayo ng tubular damage, pwedeng nagtatagal yung urine sa tubules natin at nagstay yung mga substances like your hemoglobin and they disintegrate and become hemosiderin granules at na-absorb sila ng mga RTE cells natin. Kaya minsan yung itsura ng RTE cells natin madumi tapos may mga brown granules sila. Okay? What else? Pwede din silang mag-absorb ng lipids. Okay? And when they absorb lipids, okay, we call them your oval fat bodies. Okay? Your oval fat bodies. Okay? So, halimbawa, meron siyang mga hemosiderin granules, pwede po natin i-stain yon. So, maalala nyo yung stain natin kanina, we can identify it using your Prussian blue stain. Okay? Okay. So next, we have here naman your oval fat bodies. So adding yung oval fat bodies po natin, okay, they're actually your RTE. Okay, bilog sila. Ito yung mga bilog na RTE cells natin. So, saan to galing? Anong tubule to? DCT, PCT, or yung kwan mo? Yung ano nagamunin, collecting tubules sa DCT, 'di ba? So bilog sila, okay? And then they have accumulated or absorbed lipids. Okay? So minsan other than this, okay, oval fat body, makakakita ka din adding ng mga lipid droplets. Okay? So anong ginagamit natin for identification ulit para malaman natin adding kung mga lipids ba na ito ay yung inyong manyagaminagan triglycerides and neutral fats o kaya naman cholesterol. 'Di ba? We can use your Sudan and oil red O. Kapag nag-stain sila ng red-orange, then yung lipids na yan, okay, pwedeng si triglyceride or si neutral fats. At kung hindi naman, pero using your polarizing microscope ay nagkaroon tayo ng Maltese cross formation, then we can say that those oval fat bodies contain now cholesterol. Okay? So, adding saan natin to madalas nakikita? Okay, but before that, tignan muna pala natin to. Okay? So, they stain, okay, polarizing negative structures, yung mga triglycerides natin at saka yung mga neutral fats natin. So, again, for cholesterol, ito siya adding Maltese cross formation. Kita nyo yan? Parang cross siya. Okay? Pero kumbaga yung polarized effect niya nandun sa mga edges, forming a cross-like image. Okay? So, triglycerides and neutral fat stains, okay, can be used. That's your oil red O or Sudan 3 to identify naman kung triglycerides sila or neutral fat. Bakit? Kasi with your polarizing microscope, di sila nagpo-polarize. Okay? Si cholesterol lang doon. Okay? So, ano yung clinical significance? We can see this in lipiduria, so presence of lipid in urine, in conditions like your nephrotic syndrome, acute tubular necrosis, diabetes, and your crash syndromes. So adding, pagdating po natin ng renal diseases, i-discuss natin yung nephrotic syndrome at acute tubular necrosis. Bakit may lipiduria sa nephrotic syndrome at sa acute tubular necrosis? So we'll reserve that pagdating nyo ng renal diseases next week. Okay? Okay. So next we have bacteria. Okay? So urine, sabi natin, in normal patients is usually sterile. Okay? Wala dapat tayong makikitang bacteria. Kung meron ka mang makitang bacteria at wala namang infection yung pasyente mo at nakita mo naman, okay, na wala namang white blood cells, maring contamination yan. Baka unpreserved, okay, yung urine o sobrang tagal na bago natin tinest. Okay? So, WBC should accompany bacteria in UTI. So, kailan natin ulit makisabi na ang presence ng bacteria ay caused by a true infection kapag may kasama pong WBCs. Okay? Ano na nga ulit yung explanation natin doon together with your nitrite? Ma'am, pag si nitrite mo, for example, ay positive, si leukocyte esterase mo dapat ay positive. Diba? At sa microscopic exam mo, may WBC ka. Okay? What if, for example, ma'am, negative si nitrite mo, nag-positive si leukocyte esterase mo, positive din si WBC, anong ibig sabihin? May infection ka. Okay? It's just that the infection is caused by by a non-nitrate reducing bacteria. Okay? Ma'am, what if, for example po, positive ako sa nitrite, okay? Yung leukocyte esterase ko, ma'am, negative, ngam nagadumot WBC, true infection ba yun? Still, okay? Bakit anong problema, ma'am? Ba't nag-negative yung leukocyte esterase? Ay, kasi crenated, okay? Yung mga white blood cells mo, hindi nila na-release yung leukocyte esterase na kailangan i-detect ni nigaminagan chemical reagent strip mo. So, it's a false negative result for your chem exam sa leukocyte esterase. It's still an infection kasi microscopically nakakita ka ng mga WBCs. Ma'am, what if, for example, nitrite positive siya, ma'am, walang leukocyte esterase, negative siya, wala din namang WBC. Ibig sabihin, yan ay contamination. Okay? It's something not significant. Okay? So, reporting for bacteria, we have semi-quantitative reporting using few, moderate, many, per high power field. Not low power, ha mo makita. Okay? So, guys, no, paano yung tsura ng bacteria? Makikita ka ng mga rods or mga koksay na parang gumagalaw sila. Kikita mo yung parang yung itsura na lang ading ng nakakita na kayo ng kitikiti pag nasa kanal or nasa stagnant water. Di ba parang nag-glitter-glitter sila na gumagalaw. Ganun yung itsura din sa urine. Pero miniature version niya. Okay? Kasi mas maliliit sila. Okay? So, nitrite helps confirm now rods. Okay? Not your koksay. Ano ibig sabihin? Pagka nag-positive siya sa nitrite, kunwari nag-positive siya sa leukocyte esterase, ay na-expect ko, okay, na pagtitignan ko rin yung kanyang microscopic exam, may WBC. Other than that, yung makikita kong mga bacteria ay rods or mga bacilli. Bakit? Kasi they are the ones who are nitrate reducing. So, nagpa-positive sila sa nitrite. But not with your koksay. So, pwede kasi sabi natin, positive ka sa leukocyte esterase, positive ka sa WBC, at damot bacterium microscopically, pero negative ka sa nitrite. Apay mamhan nga nag-positive dun sa nitrite. Kasi baka nga yung bacteria mo naman is non-nitrate reducing. Like for example, yung staphylococci mo, ganun. That cause now UTI. Okay? So, yun yung tatandaan nyo dyan. Okay? So next, we have here yung yeast natin, okay? So single refractile budding structure. Saan natin to madalas na pagkakamalan? Sa red cell natin, okay? So adding, we have here a picture. Kung makikita mo, compared to your red cell, mas kitang-kita mo, okay? Si budding yeast, okay? Actually, meron dito. Ayan o, red cell yan. Very faint siya, okay? Ito, kitang-kita mo siya. Okay, minsan nag-ooblong pa yung shape nila, tapos pinball pa madalas yung shape nila kasi budding siya, okay? Yan, yung itsura niya, okay? And sometimes, we can also see presence of your mycelium, okay? So, yan siya, parang mga stems or branches, okay? So, that confirms, okay, na yeast nga yung nakikita natin, okay? So, reporting, we use semi-quantitative reporting like few, moderate, many, okay? So, ano yung correlation nito? Dahil na kapag diabetic yung patient natin, pwede din tayo makakita na strongly positive na glucose chemical exam result, okay? So, saan natin madalas nakikita to guys? Sa mga immunocompromised patients. Example, di ba, yung mga HIV/AIDS people, di ba? Minsan, or madalas, meron po sila nito, mga Candida albicans infection, di ba, oral thrust. Other than that, meron din silang moniliasis, okay, or vaginal moniliasis. O kaya sa mga aged women, okay, nakikita natin to, okay? So, nitrite negative, but WBCs are present. Para masabi natin na true infection. What if, for example, may yeast pero walang WBC? Maring contaminant siya. Okay? So again, sometimes our yeast can be confused with your RBCs. Okay? So anong difference nila? May budding. Other than that, it's more visible than your red cell and it's more or it's highly refractile compared to that of your red cell. Okay? Okay, so next, we have parasites, okay? So adding dito naman sa parasites, the most common guys no is yung Trichomonas vaginalis, okay? So 'di ba syempre nalalaman natin yung pasyente kung may ganito lalo na kung nagrereklamo siya ng pangangati, 'di ba? So alam niyo naman dito sa parasitology guys. Okay, so for the reporting of parasites, just like no other formed elements, we semi-quantitatively report is as few, moderate, many. So minsan ading nakikita natin tong trichomonas, okay? Gumagalaw pa talaga siya. Doon yung tumbling motility, okay? So if not moving, your trichomonas may resemble your WBC, okay? O kaya yung transitional urothelium, lalo na ading yung caudate ninyo, okay? O kaya yung RTE cells natin, okay? So that's why we have, okay, to check then patient symptoms. But of course, that's not our work. That's the work of our physician, okay? Other parasites, no, other than your Trichomonas vaginalis, we have your Schistosoma hematobium, ova, okay, or yung Enterobius vermicularis. 'Di ba napag-aralan niyo yan ading sa minaganan sa parasitology ninyo? For Schistosoma hematobium, 'di ba? Meron tayo nung parang terminal spine niya na ganun. Oh, makikita niyo siya sa urine. Or for your Enterobius vermicularis, yung worm, pinworm ko na kumaday, egg na cut D-shape, 'di ba? Flat sa parang isang side niya. So makikita mo siya. Pwedeng maihalo doon sa urine ng ating pasyente. Okay? Kasi 'di ba minsan kasi yung D-shape ova na yan, naglalad siya doon sa labasan ng tae. Okay? Sa ubet mo. Okay? At pag naihi ka, minsan nasasama siya during the collection. Okay? So, next. Okay. Also, we have sperm. Okay? So, sabi ko, we can see presence of spermatozoa sa mga female patients natin or sa male. Okay? So, for male patients, pwedeng insignificant siya or pwedeng significant. Like for example, when that patient no is infertile. Okay? So, ano yung example nito? In retrograde ejaculation. Sira yung letter L ko. Retro. Q. Letter I na lang guys, big I. Nay. Yan. Ejaculation. Okay? So in retrograde ejaculation, anong nangyari ading? Okay? So 'di ba, ito yung bladder ng male patient, okay? So ito yung urethra palabas dun sa penis niya, okay? So yung ihi kasi, for example, this is where yung ating semen, okay, ay dumadaan papunta dun sa urethra natin, okay? So guys, pag nag-ejaculate yung lalaki, okay, lalabas, 'di ba? Isa lang kasi yung labasan ng urine at saka nung semen. So pagka nag-ejaculate siya, lalabas dito, papunta doon, okay, lalabas sa penis, okay? Pero ang nangyari dun sa pasyente na merong retrograde ejaculation, pag nag-ejaculate siya, hindi na nagsasara yung sphincter. Normally kasi pagka nag-ejaculate yung pasyente, nagsasala yung sphincter dito para sa ganon, yung semen lalabas lang dun sa penis, hindi siya mapupunta sa bladder. But in patients with retrograde ejaculation, nasira yung sphincter. Okay? Kaya pag nag-ejaculate siya, instead na pupunta doon lahat, yung iba na pupunta dun sa bladder. Kaya pag naihi yung pasyente, meron ng kasamang mga sperm papunta dun sa ihi na ilalabas niya. Okay? So, yung mga pasyenteng meron nito, minsan infertile po sila. Okay? So, it may also cause positive protein. Okay? So, sa chem exam ninyo, pwedeng mag-positive po siya. Bakit? Kasi because of the content, okay, of your semen. Okay? Reporting varies with laboratories. So, like for example, pag nakita mo siya sa isang teenager na babae, hindi na po natin siya nire-report usually. Amumlatan, okay? Huwag ka na maingay, okay? So, for female patients, siguro when the doctor is using that no to check for infertility, then we report, okay? For example, for young children, female, okay, patients, for example, na merong presence nun, ay baka sila po ay victim, okay, ng rape. So, there's legal consequences, okay, to it. So, pwedeng tawagin ka, okay, yung medtech na nakakita nun sa korte, okay, and you'll report kung ano nakita mo. Sasabihin mo na nakita mo dun sa urine ng pasyente, okay? So, pwede kasi na-rape siya, okay? And that will be used, okay, as a strong evidence against the suspect, okay? So, next, we also have your mucus, okay? Your mucus, okay, are produced, okay, from your renal, or it's a protein, okay, produced from your RTE, okay, yung glands ninyo and the squamous cells. So normal to guys, usually not significant, okay? And madami to, lalo-lalo na po sa mga babae. So we report this as your mucus threads, okay? So sometimes if we confuse them with our casts, pero madalang lang kasi yung shape naman nila bizarre, okay? Mga parang magulo lang, okay? So unlike yung cast ninyo, usually form siya like parang ganyan yung form kasi nila madalas. Okay, cylindrical. Okay? So though sometimes okay may mga mucus okay kasi threads na parang nag-a-appear na ganito pero rare lang 'yon. Okay? And of course unlike yung cast natin, wala po siyang mga granules sa loob nito. Okay? It's just like a fibril or a thread. Okay? So irregular, okay, and is composed of your TAM horsefall protein. Actually, your TAM horsefall protein adding or yung tinatawag po nilang uromodulin. Walang L, so yan, uromodulin. Uromodulin yun guys, baka kasalanan ko mamaya L yan. Wala kasing L yung kwan ko. Nasira yung keyboard, okay? So uromodulin or your TAM horsefall protein, okay, is the major component, okay, of your mucus and of course the matrix okay that forms yung ating mga urinary casts. Okay? So for female specimens, madalas po natin siyang makita, okay? And it's of no clinical significance. Okay? So katulad din adding ng squamous epithelial, minsan nakakadagdag din sila sa pagulo. Okay? Kasi inobscure nila yung mga mas importante pa dapat nating makita. Okay? So next, we have here naman yung mga casts natin. Okay? Adding, no, unlike yung mga nauna nating na-discuss, yung casts po natin, okay, ay, they are elements that are unique to the kidney. Okay, like for example, sabi natin, di ba yung red blood cell, pag nakakita tayo, hindi ibig sabihin na galing sa kidney yun. Pwedeng kasi galing yun sa circulation natin, nasira yung glomerulus natin, okay, kaya napunta sa urine. O kaya naman galing siya sa kidney, like for example, nagkaroon ng gas-gas yung kidney natin because of nagaminaganan because of kidney stones. So, pwedeng sa kidney, pwedeng renal or non-renal, okay, yung origin ng mga elements na yun. Also with your white blood cells, mga ganyan. But with your casts, okay, they are unique to the kidney. Sa kidney sila. They're actually formed now, okay? How do you call this one? Imitating yung shape ng ating mga tubules. Okay? Saan sila na-form? Sa distal convoluted tubule natin at sa collecting duct. Kaya yung shape po nila, cylindrical. Okay? Long and cylindrical sila madalas. Okay? So they have parallel sides, okay, with rounded ends. So rounded yung ends nila. And of course, with inclusions. So paano mo pinapangalanan yung cast mo? Kung siya po ay naglalaman ng mga red blood cells, then we call it your red blood cell cast. Kung siya ay naglalaman ng mga white blood cells, then we call it your white blood cell cast, and so on. Okay? So your cast, okay, we detect them saan? Under your low power. In most laboratories, the reporting is under per low power field. Pero ulitin ko, when we're going to identify them, okay? After mong after mong makita sila under low power, you have to view them under your high power objective para makita mo, ay, anong klaseng cast ba ito? Okay? Gaminagan, red blood cell cast ba to? So makikita mo dun kung red cell ba yung nasa loob o white blood cell ba, okay? Or granular cast ba o bacterial cast ba siya? Okay? And of course, when we're doing, okay, the slide method for examining urine sediments, anong gagawin natin, guys? We scan the edges, okay, of the cover slip. Bakit? Why do we have, okay, to scan the edges? Sabi natin, di ba, mabibigat, okay, yung mga cast natin. So, napupunta sila, guys, dun sa gilid-gilid, okay, nung ating cover slip. So, we have to scan them. Baka ma-miss natin sila, okay? So, low light is essential. Bakit? Lalong-lalo na adding dun sa mga gaminagan yung hyaline cast natin, for example, okay, compared to other cast like your waxy, ang hirap po niyang makita, okay? Parang tulad ng red cell mo, parang mumulang siya, okay? So you have to examine them under your low light kasi very low yung kanilang refractive index, lalo na unstained yung material natin, okay? So saan po natin re-report? In most labs, they report it per low power field. Identification is just or high power field is just used for identification. Okay? So what are the causes of casts appearing in the urine? Pwedeng pathologic o pwede namang non-pathologic. Halimbawa ng non-pathologic adding, yung hyaline cast ninyo, yung RBC cast ninyo, pwede po natin siya makita in strenuous exercise. Okay? Normal lang yun. Okay? But for pathologic causes, example, the presence of your RBC cast, tapos meron ka pang significant amount ng red blood cell, okay? So pwede because of glomerular damage. Okay? O kaya naman may presence ka pa ng white blood cell cast, may presence ka ng bacteria, dapay ti positive leukocyte esterase mo, may positive nitrite ka din sa chem exam. Okay, yung pasyente ko merong pyelonephritis. Okay? So pathologic. Okay? So tignan natin. Okay, so we have here the composition and formation, okay, of our ano gamin na ganun? Cas, okay? So 11:30 na pala kasi guys. Okay? So we have the TAM horsefall protein or yung uromodulin ninyo. So guys, the matrix, okay, of our matrix component, okay, of our Cas, okay, is how do you call this one? Mainly, okay, composed of your TAM horsefall or made of your TAM horsefall or your uromodulin. Okay, so this is a protein secreted by your RTE, your DCT, and your collecting duct. Okay, so there's a consistent excretion of your TAM horsefall, okay, in normal patients, and this usually increase in stress and exercise. Kaya nga adding, di ba, sabi ko sa inyo, in strenuous exercise, pwede tayo merong physiologic appearance, okay, ng inyong CAS. Okay, so it's non-pathologic. Okay, so formation of protein fibrils into matrix. Okay, so these proteins, okay, your TAM horsefall protein fibrils now will form, okay, into matrix. So parang yung supot, okay, nung inyong CAS. Okay, especially, okay, so when there's urine stasis. Okay, when we say urine stasis, there's urine retention. Okay? So kaya nga 'di ba guys, hindi maganda talaga din yung nagpipigil kayo ng ng ihi nyo. Kung naihi kayo, umisbo kayo, okay? Mas prone pa kayo magkaroon ng infection, UTI. Okay? Kasi tumatagal yung ihi nyo doon, okay? Sa ano ninyo, sa kidney nyo, okay? So acid pH, okay, when the urine is acidic then, okay, that contributes, okay, to formation of your CAS and presence of your sodium and calcium. So these are factors, guys, okay, that favor the formation, okay, of your urinary CAS. Okay, so the TAM horsefall protein adding, they are not detected by your reagent strip. Okay, hindi po sila na-detect. Kaya kung sakali man, okay, na sobrang dami, okay, nung mga mucus threads mo o kaya yung mga hyaline cast mo, pwede kasi na negative pa rin yung protein mo. But if for example, there's presence of much of this, tapos increase yung protein mo or yung result mo for protein sa chem exam, it's not because of the large amount of these CAS or of the TAM horsefall protein, it's because of what? Presence of a renal disease. Kasi nga, si TAM horsefall, di naman siya na-detect ng reagent strip po natin. Okay? So next, so we have here the formation, okay, of our CAS. So number one, we have aggregation of the TAM horsefall fibrils, okay, to our RTEs. So nag-a-attach sila dun sa kidney tubules natin, okay? Then after that, they're interweave to loose networks and they trap elements. So halimbawa adding, yung pasyente merong glomerular bleeding. 'Di ba? Pag may glomerular bleeding, kunatayukot at the red cell, 'di ba? So kung yung sa tubule natin, okay, andyan yung mga TAM horsefall fibrils natin, okay? At nag-form sila ng matrix, yung mga red cell na dumadaan dito, tinatrap nila. Kaya in glomerular bleeding or damage, meron din tayong presence ng RBC CAS, okay? Because of that. So natatrap sila. Okay? Or minsan may WBC cast pa kasi sa sobrang sira na nung glomerulus mo, hindi na lang okay red cell yung lumalabas, pati yung mga white blood cells mo matrap damot okay doon sa matrix. Iso dapay RBC cast mo, adapay WBC cast mo. Okay? O kaya naman meron kang pyelonephritis, okay? Upper urinary tract infection, okay? So there's how do you call this one? Formation of the Tam Horsful fibrils, okay? So nagkaroon tayo ng how do you call this one? Proliferation, okay, of past cells or white blood cells dun sa area of infection, natatrap din sila doon. Kaya in pyelonephritis adding, meron tayong white blood cell cast. And that's how we differentiate your pyelonephritis from your cystitis, okay? Adding sa pyelonephritis, meron tayong white blood cell, bacteria, pwedeng positive si bacteria. Sa chem exam, pwede sa nitrite, kakusana, and leukocyte esterase. And there's also presence of what? White blood cell cast na hindi present sa cystitis. Bakit? Kasi di ba malala nyo, kung ito yung kidneys natin, okay, these are the ureters, ito yung bladder nyo. Pag bladder yung infection mo, that's cystitis. That's, di ba, outside the kidney na. Pag if it's pyelonephritis, upper UTI, ito yung involved. Okay? So, tao dito, kung sabi natin your casts are unique to the kidneys. Okay? So, if it's pyelonephritis, or an infection with WBC cast, then that's pyelonephritis. Pero if it's an infection, okay, without presence of WBC cast, maring baka cystitis lang yan. Okay? Dito lang siya. Okay? Kasi wala namang formation ng cast dito. Okay? Dito sa kidneys mo ang meron. Okay? So, next. And then, attachment of the elements to the matrix. Then after that, yung matrix natin na punong-puno na ngayon ng mga laman. Kung kunwari, red blood cell yan, red blood cell cast ito, hihiwalay na siya ngayon dun sa tubules natin, dun sa mga epithelial cells sa lining ng tubules natin or yung mga RTEs natin. And that detachment will lead to excretion of the cast dun sa ating urine. Okay? So next, we have naman what we call your cylindroids. So adding your cylindroids, okay, are similar to your cast and they have no same significance. Pero ang problema lang kasi natin dun sa cylindroids, 'di ba yung mga cast natin they have parallel sides with we call this one circular edges, okay, or oval edges or rounded edges. Yung cylindroids ninyo, ganito yung tsura niya, tapered yung end. Pwedeng sa one side o kaya ganun. Okay? Kaslataki. O parang kamote. Okay? So, ganyan yung itsura ng mga cylindroids natin, guys. But they have same significance, okay? As that of your cast. Okay? Okay. So, we have here, no, the different types of cast. We have your hyaline cast. Okay? So, your hyaline cast, okay, has no low refractive index. Kaya nga sabi natin, we view them adding saan? In low light. Okay? Or in phase contrast microscope. Kasi unstained yung material natin. So, napakahirap na tingnan, okay? Or hanapin yung hyaline. Kitam atoy, ito siya, oh. Halos parang hindi mo alam kung guni-guni mo lang ba siya at nandyan siya. Okay? So, napaka-faint niya. In short, adding, kapag malabo po yung mata mo, magsalamin ka na kapag nagpa-practice ka na, okay? Kasi mo nga makita, ma-miss mo ata, okay? So, normal parallel sides or convoluted or minsan wrinkled siya. Okay? Bakit? Kasi dehydrated cast na ito. Natanggal na yung water content niya. Okay? So, next. So, we have here, okay, another picture of our hyaline. Nakita yung atoy. Ayan siya guys, oh, napaka-faint niya. Ayan, okay? So, very faint siya, okay? And then we also have here, no, another one. Ito medyo nag-disintegrate na siya adding. Siguro medyo matagal na siya doon sa tubules natin. Kailan ito nangyayari kapag meron tayong urine retention? Halimbawa, yung mga pasyente natin na merong Bisaya ka man nung merong renal damage, okay? So, nagkakaroon sila ng extreme urine stasis. Nagtatagal yung cast doon hanggang nagdi-disintegrate, and yung cast na yun pwedeng maging granular cast o pwede na siyang maging waxy cast, okay? So, medyo may mga jagged edges siya, okay? So, that's your hyaline cast, okay? So, ulitin ko, pwedeng non-pathologic, okay, yung reason ba't nandyan siya. Like, for example, in strenuous exercise, okay? So, clinical significance, presence of these in 0 to 2 is still normal. So, example of causes, non-pathologic, we have stress, exercise, fever, heat exposure, and dehydration. For pathologic causes, anong example natin? In glomerulonephritis, in infections like your payelo, ulitin ko ha, pyelonephritis. Walang cystitis. Bakit si cystitis mo? That's after the kidney. It only involves yung bladder natin. Okay? Sabi mo, yung kas mo sa kidney na form. Okay? So, chronic renal disease and in congestive heart failure. Okay? So, this is Cova-stained material. So, kitang-kita mo siya. Also, in phase contrast, very obvious siya. Okay? So, next, we can also see here presence of your hyaline cast. So, meron siyang mga granules adding. Okay? Another in this one. Okay? Meron siyang mga granules. Bakit? Kasama niya kasi ito. Parang cast ito, di ba guys? Ngem hanga cast atoy. Okay? This is amorphous urates. Okay? Acidic urine with this amorphous urates. Kung makikita nyo, wala siyang matrix o walang balot, nagkumpul-kumpul lang sila kaya nagmukha silang kas pero awang mati cover na niya, okay? Unlike this one, okay? Kita mo yung border niya, okay? So those are the pictures of your hyaline cast, okay? So next, we have RBC casts, okay? So they are orange-red in color, okay? Especially when we stain them, okay? And ito yung appearance niya. Minsan brownish yung kulay niya due to presence then of hemoglobin, okay? And sometimes they may be fragmented. Kaya tignan nyo to. Andito yung matrix. Napansin nyo guys, may balot siya o very, very faint lang. Ayan siya. So may mga portion na may mga red cell, may portion na wala. Okay? So anong tatandaan ninyo? Sabi niya, confirm seeing free RBCs and positive reagent strip for blood. Halimbawa, nakakita ka tikastoy, wala man lang free red blood cell. Negative naman yung chemical exam mo for blood. Abay, baka hindi naman. Okay? RBC cast yung nakita mo. Baka naman WBC cast, di mo lang ma-identify o kaya granular cast. Okay? So we can confirm this, okay, by looking dun sa kanyang paligid. So kung makakita ka ng ganitong cast, ay may mga parang double-walled cells doon. Other than that, makikita mo rin sa paligid niya guys, napakadaming mga red blood cells. Okay? And check mo din yung kanyang chemical exam result. Positive siya sa blood. Okay? So look for cast matrix to avoid mistaking a RBC clump for a cast. Kasi minsan, pag sa sobrang dami po ng mga red blood cells natin adding, nagkukumpul-kumpul po sila. Kaya pansinin mong mabuti, baka akala mo cast yan, nagkumpul lang sila. Hanapin mo kung merong parang supot. Yung matrix, ito siya, very faint lang. Okay? So tignan mo. In short, bawal malabo mata. Okay? Magpa-EO. Charot. Okay? So next, we have here the clinical significance. Okay? So bleeding within the nephron. Okay? Casts are more specific than free RBCs in urine. So alimbawa daw, nagkaroon tayo ng bleeding, okay, doon sa nephron natin. If the bleeding kasi ading is coming from the, for example, nagaminagan menstrual contamination, mga ganon, or bleeding, for example, coming from the bladder, okay? Walang cast yun, okay? But in specimen with presence of RBC cast, okay, that can give you a confirmation that the bleeding is actually involving the kidney or the nephrons, okay, of the kidney, okay? So this is common, okay, commonly seen in glomerular damage, okay, or nephron capillary damage. Okay? sabi ko nga sa inyo, kapag sobrang sira na yung glomerular membrane natin, okay, or nagkaroon tayo ng damage doon sa surrounding, di ba, capillaries doon sa nephron natin or sa kidney tubules. Maalala nyo, in renal anatomy and physiology, surrounding your tubules, okay, meron tayo dyan yung vasa recta ninyo or yung mga surrounding capillaries natin. So pag na-injure yung mga yon, they may, okay, cause leakage, okay. So glomerular damage, okay, we can also see what? Presence of dysmorphic RBCs. For example, yung mga acanthocytic RBCs, those with blebs or protrusions. And of course, elevated protein. Okay? Kasi hindi na lang po red cells minsan, okay, nasasama natin. Kasama yung mga protein components sa plasma natin. Okay? But of course, you have to take note, minsan yung RBC cast natin, nakikita natin in non-pathologic causes like strenuous exercise. And this is usually transient. Okay? So next, ayan. So, when there's no extreme urine stasis, okay, or retention of urine, like for example, in renal failure patients, nagkakaroon na tayo guys ng disintegration, okay, nung mga cells natin. So, ano nangyayari? Okay? Ang nangyayari, minsan maburbur ko na, di ba, yung mga red cell natin. So, ang nangyayari natin, instead of RBC cast nakikita natin, parang granular cast na dirty brown cast. Ang laman actually nyon ay yung degraded hemoglobin natin to your methemoglobin. Okay, so para siyang kasya na madumi na may mga maliliit. Minsan may mga red cell ka pang makikita, minsan puro granules na lang. Okay, so that's a dirty brown cast. Okay, so kailan to nangyayari? Kapag extreme yung urine stasis. Yung red blood cell cast mo na form siya pero hindi siya kaagad na release dun sa urine mo because of what? Retention of urine sa tubule. Sobrang tagal niya doon hanggang nag-disintegrate siya. Hanggang na naging dirty brown cast. Okay, isuna. Okay? So, look for RTE cells to confirm tubular necrosis. Okay? For example, nakakita tayo ng dirty brown cast. Ba't ka pa maghahanap ng RTE cells? Kasi di ba maalala nyo guys, sabi natin, pag na-expose yung kidney tubules natin sa hemoglobin, toxic yun para dun sa ating kidney tubules. So that can cause necrosis. Okay? So pwedeng may presence ng dirty brown cast together with RTE cells or pwede ding may mga RTE cast. Okay? Cell cast. Okay? So, pwedeng ang pasyente natin merong tubular damage na. Okay? Due to exposure to, toxic hemoglobin. Okay. So, ayan. Adatoy. Mayroon tayong picture dito, guys, nung dirty brown cast natin. Okay? So, if you can see here, presence of hemoglobin pigment, brownish in color. Okay? And then we have here your granular dirty brown cast. Okay? So, these are what? Degraded hemoglobin to your methemoglobin. And kailan ito nangyayari? Lalo na kapag nagkaroon tayo ng extreme urine stasis. Okay? So, next, we have naman yung WBC cast ninyo. Guys, it's 12 I'll just finish siguro hanggang dito, okay? Kasi may klase si section, tama ba ako? Section C. So, ang gagawin natin mamaya, i-break ko po ito and I'll just upload the pre-recorded lecture, okay? Na nagamit ko last year. So, yun na lang yung i-upload ko for you to view for 3A. Pwede nyo siyang panoorin after this session kasi it's been 3 hours na tayo, okay, for a virtual class. Medyo lengthy siya, okay? Yeah, pwede nyo panoorin yon. For 3C, pwede nyo pong panoorin, pakinggan yung kadugtong nung lecture natin kung ano man yung matapos natin ngayon sa vacant time ninyo. Okay ba yon?
Yes, ma'am.
So, ma'am.
Okay. So for WBC cast, okay, sabi niya mostly neutrophils, okay, and lobe, nucleus, and granules, okay, are seen. So makikita nyo dyan guys, so this is a covastate material. Makikita mo, di ba, enhance yung kanyang multi-lobe nuclei. And tatandaan nyo, just like dun sa red cell clamps natin, tignan din natin, baka naman, kumpul-kumpul lang na WBC yan. Tignan mo kung may presence ng parang supot or nung matrix niya. Okay? So staining helps now to differentiate your white blood cell cast from your RTE cell casts. Okay? Okay, so we can use that, okay, to enhance, okay, yung kanilang nuclear details. So if you can see there's no hypersegmented nuclei, multi-lobe nuclei, then more likely that's your WBC Cas and not your RTE. And for RTE kasi medyo mas malaki sila compared dun sa WBC natin. Okay? So they may be tightly packed. Okay? So look for Cas matrix to distinguish it from your WBC clump. Kasi baka naman pala kumpul lang, okay, ng WBC yan. At hindi yan white blood cell Cas. Okay? So next, WBC Cas are seen with infection and inflammation, okay, of the tubules. So tatandaan natin yung sinabi ko kanina sa inyo guys, paano natin madi-differentiate si payelo from your cystitis? Si payelo, pag may presence ng WBCs, may presence ng bacteria, positive for example yung nitrite mo and leukocyte esterase, at meron pa rin siyang Cas, okay, na hindi po natin makikita sa cystitis or lower UTI. Si lower UTI pwedeng positive din siya sa WBC or leukocyte esterase, may mga WBC cells siya or WB cells siya, may mga bacteria, pero wala po siyang WBC Cas. Hindi siya pwedeng magkaroon. Okay, kasi if it's that cystitis, bladder lang yung involved mo dyan. Okay? Pero minsan kasi, di ba, yung cystitis natin, pag napabayaan, nagkakaroon po, okay, nung tao dito, umaakyat, okay, yung infection hanggang makarating siya sa kidneys. Okay, so hindi dapat natin binabaliwala. Okay, kahit yung simple or mild UTI na sinasabi nila, paggamot natin. Kasi pwede tayong maging asymptomatic for a while, tapos less we know, nakaabot na siya sa kidneys natin at sinira niya na yung kidney natin. So pag napabayaan, pwedeng maging mag-cause siya ng renal failure. Okay? So acute interstitial nephritis, okay? Again, in acute interstitial nephritis naman, adding how we're going to differentiate it with from your pyelonephritis, merong WBC Cas pero walang bacteria. Okay? So may WBC Cas siya pero wala po siyang bacteria. Okay, kasi the cause is not bacterial. Okay? So it may accompany then your red blood cell Cas in pyelonephritis. Okay? Kasi minsan, lalo na pagka severe na yung infection, guys, nasa severe, or I mean severe na rin, pati yung mga interstitial or yung mga tissues, surrounding tissues natin, and that may lead to bleeding. Okay? So minsan natatrap pati mga red cells. Kaya may RBC Cas na din. Okay? But you have to take note, minsan in glomerular damage, okay, meron din tayong presence of WBC Cas together with RBC. So we always check, okay, dun sa symptoms din ng pasyente natin. Okay? So next, we have bacterial Cas. Okay? So adding, syempre ang laman po niya ay bacteria. So pwedeng pure bacteria yung laman niya or bacteria with mixed WBC. Saan to natin nakikita? Pwede din po sa pyelonephritis or in glomerular nephritis. Okay? Kasi 'di ba sa pyelonephritis, guys, meron tayong bacteria. So pwede ding magkaroon tayo dun, guys, ng bacterial Cas. Okay, other than the presence of WBC Cas. So a mixed Cas, pwede possible siya. Okay? Resemble granular Cas. Bakit? Kasi granular Cas nyo, 'di ba, napakaliliit. Okay? But paano natin malalaman kung bacterial Cas ba siya or granular Cas? Tignan natin, okay, kung ano yung nasa kanyang paligid. Okay? For example, if there's presence of many bacteria, okay, then more likely that's a bacterial Cas. Okay? Minsan nagmo-move, 'di ba, yung mga bacteria natin. Okay? And of course, we look, okay, for presence of free WBCs. Okay? That indicates what? Maybe true infection. Okay? So, confirm using your gram stain. So, we can stain them, okay? If it gives you a violet purplish color, that may indicate na that's a, infection with a gram-positive microorganism, or a pink color, a gram-neg organism. Okay? So, this can also be seen, sabi ko, in your pyelonephritis. Okay? So for mixed cellular Cas, we can also see it in your glomerulonephritis. That's a combination adding of your red blood cells and that of your white blood cells. Okay? So next. So tandaan ninyo ito. Wait. Ayan. Okay, so for glomerulonephritis, we have RBCs and your WBCs. Kapag yung pyelonephritis, ano yung nakikita natin, ading? Meron kang, that's pyelonephritis, pwedeng may WBC cas, may WBCs, di ba, white blood cells, and then meron ka ding bacterial casts. Okay? O kaya naman minsan, in severe pyelonephritis, meron din silang presence, ading, ng renal tubular epithelial cells. Okay? Bakit? Kasi na-damage na rin, okay? Pati yung mga tubules ng kidney natin. Okay? Kasi that's your upper UTI. Okay? So, look for predominant type of cell. Okay? So, pag nakita mo may RBC cas, may WBC cas, ngem awamot bacteria na, okay, ay, baka hindi nga siya infection or hindi siya pyelonephritis. Baka siya ay glomerular nephritis. Okay? So, that's an example. So we have here, okay, the next we have your epithelial cast, okay? So saan na form in your distal convoluted tubule. So kung makikita nyo, ading, anong nakikita nyo sa loob? Round cells. Kaya saan natin to madalas na pagkakamalan? Akala natin mga WBC cast. So anong gagamitin natin? Observe natin yung nuclei. Kung multi-lobe ba siya o single lobe lang siya that eccentrically located. Okay? And of course, katulad ng white blood cell and RBCs natin, tignan natin, baka clumps lang naman siya. Okay? At hindi siya cas kasi wala naman yung matrix. So, observe natin kung may supot siya. Okay? So, majority of cells are on the cas matrix and some ay nakikita natin sa labas. Kasi you have to take note na itong epithelial cas natin or RTE cas are actually formed by your matrix plus your RTE cells. Saan ba naka-attach yung cas natin or yung matrix pag nangunguha pa lang siya ng laman nung cas? Di ba dun sa RTE cells mismo lagapan natin? So, pwedeng may attach sa labas. Okay? So, we should differentiate it from WBCs. Okay? So, like for example, we can use staining techniques, okay? Or we can use your acetic acid, okay, to enhance nuclear detail for your WBC. Okay? Or for staining naman for your RTE to show now the single nucleus. Okay? That is again eccentrically located. Okay? So what's the clinical significance? Just like adding dun sa renal tubular epithelial cells natin, the presence of your RTE cas, okay, indicate tubular damage. Okay, example, due to exposure of our tubules to heavy metals, viral infections, drug toxicity, graft rejections, or in infections like your pyelonephritis. So ulitin ko, in pyelonephritis adding, hindi ka lang makakakita ng WBC cas o ng bacterial cas or pwede kasing minsan may RBC cas din, makakakita ka din ading possibly ng mga renal tubular epithelial cas. Okay? Kasi severe na yung mismong tubule nung ating or tissue nung ating kidney tubules. Okay? Cells may also appear bilirubin stained or brown yung kanilang kulay. Example, this one, okay? In patients with hepatitis. Okay? So again, anong gagawin natin? Kung talaga ba ito ay mga fragments, okay, o nagkumpul-kumpul lang, hanapin natin yung matrix para makita natin kung talaga bang RTE cas siya or RTE cells lang na nagkumpu-kumpul. Okay? Okay. So next we have your fatty casts, okay? So they're seen, okay, with your oval fat bodies. So kung makikita nyo guys, if you observe, di ba, makikita nyo, ang layo, hindi mo siya pwedeng mapagkamalian na bacterial cast or red cell. Kasi kita mo guys, yung mga bilog niya, very refractile. They're highly refractile, okay? And if we're going to view them under your polarized microscope, okay, kitang-kita mo yung polarization, lalo na if that's your cholesterol, okay, components, okay? So saan natin nakikita? Katulad din nung ating mga oval fat bodies, okay? Or nung fat droplets natin, we can see them in nephrotic syndrome, in diabetes, in crash trauma, or tubular necrosis. Okay? So ulitin ko ading, paano natin kino-confirm ulit kung yung cas ba na yun ay talagang yung cas na in-identify natin? Like for example, if that's really an RBC cas, titignan natin yung paligid. 'Di ba? Kung para sa'yo, RBC cas yan, ngam awamot, uray may sa red cell, ijay paligid na. Tapos di naman nag-positive yung iyong chem exam for blood, then maaaring hindi yan red cell cas. Okay? So, baka naman nagkamali ka. Baka that's a fatty cas. Okay? So, tingnan natin. Okay? Okay, next we have the granular cast. Okay, so yung granular cast po natin, pwede po siyang coarse and finely granular. But in the lab, no, hindi na natin na-identify kung coarse ba siya or fine. Basta kung natayo latakot, granular. Okay, so ano yung origin niya? They're coming from the lysosomes of our RTE, okay, and they are usually excreted, okay, as part of normal metabolism. Okay, o kaya naman other physiologic causes like after exercise and strenuous activities. Okay, so normal siya. Pwedeng normal. O kaya naman ading minsan, pag nagdi-disintegrate na yung mga red blood cells nyo, they appear like your granular cast. Okay, so yung, alimbawa, di ba, yung dirty brown cast ninyo, kamukha niya. Okay, so, kunwari, nagkaroon ng disintegration ng cellular cast, hanapin mo ano yung mga kasama niya. Okay, red cell ba yung mga kasama niya? Okay, or ano ba? Okay, yung mga kasama niya. So, for example, nakita mo kastoy, dati granular cast, at nakita mo sobrang dami ng mga red cell. Ah, okay. So, itong granular cast nito ay maaaring nag-disintegrate na red blood cell cast. Okay, so that's an example. Okay, so next, Chris, medyo binibilisan ko na ha. Okay. So next, again, just like any other cast, we detect them at low power objective. Kamukha niya nga yung hyalin nyo guys. It's just that napakadumi ng loob. Diba? So for identification, we use your high power. Okay? So the granules disintegrate, okay, further, lalo na pag there's extreme urine stasis, example, in patients with renal failure, at nagkakaroon ng formation ngayon ng waxy cast natin. Yung granular cast natin, nagiging waxy cast sila. Okay? At si waxy cast, guys, no, iba po siya doon sa ating hyalin. Si hyalin, faint yung itsura niya. Si waxy, mas highly refractile. So parang kung i-compare mo, ading, yung red cell, di ba parang mumu siya, napaka-faint, pero pagka badinggis yan, o kaya bubbles, ano siya, highly refractile. So parang ganun yung comparison natin sa waxy cast at sa hyalin. Si hyalin, napaka-faint niya. Si waxy, it's refractile. Okay? Highly refractile. So differentiate granular cast from clumps of debris and crystals. Okay? So, katulad, tignan mo, baka naman ang granular cast ata, awamot matrix na. Kut amorphous uriates lagayam. Okay nga, nagkumpul-kumpul. Okay? So, i-check mo yung presence ng matrix bago mong sabihin cast yun. Okay? So, katulad niyan, paano natin malalaman kung anong klaseng granular cast yan or ano yung na-disintegrate na cast at naging granular? Tignan natin yung paligid. So, kung makita natin, ang dami-daming mga white blood cells. So, maaaring yan ay white blood cells na nag-disintegrate. Sobrang tagal niya na doon sa tubules, okay, nung kidney ng pasyente natin at nag-disintegrate and eventually became your granular cast. Okay? So next, we have here the picture of your waxy cast. Okay? So kailan ulit nagkakaroon tayo ng waxy cast? Example sa mga pasyente ading na may renal failure. Yung mga granular cast, sobrang katagal na nila sa tubules, okay? Nag-disintegrate sila further and they become your waxy cast. So kung makikita nyo ading, your waxy cast are brittle, okay? And they are highly refractile. Magkamukha sila, 'di ba? Nung iyong nagaminaganan, hyalin cast. Pero ito, litaw na litaw. Okay, yung itsura niya. Okay? And often with fragmented jagged ends and notches. Okay? Those fragmented ends or notches, okay, are brought by the disintegration caused by, extreme urine stasis. Okay? So, we can visualize them using yung stain. So, we have here examples, yung mga Cova stain materials natin. Okay? So again, your waxy casts, okay, are actually degenerated hyalin and your granular casts. Okay? So, okay. So guys, anong cast ang wag na pala. Okay? Nalimutan ko yung joke ko, guys. Okay? Nagugutom na ako. So, broadcast. Okay? Headline bukas, ngayon ang broadcast. Okay? So, guys, no, yung broadcast natin, we call it as your renal failure cast. Okay? So, ano yung nangyari? Bakit broad siya, malaki, okay, malapad, okay? 'Di ba sabi natin yung cast natin na form sa DCT natin, okay, or sa CT. Guys, no, yung ating broadcast, nagkaroon na ng sira yung tubule natin at lumapad sila. Okay? And this is commonly seen sa mga renal failure patients natin. So, kita mo to, sobrang lapad niya compared dun sa normal na mga cast natin. Okay? So, formation is in the upper collecting duct. Okay? And this, how do you call this one? And eventually, okay, doon sa from the DCT to the collecting duct. Okay? So, widened, okay, yung mga tubules na yon. Okay? Due to damage, okay, dun sa mga tubules natin. Like, for example nga, in renal failure, okay, patients. Okay? So, sabi niya, adding, all types of casts may be broad. So, pwedeng si RBC cast mo ay maging broadcast. Pwede si WBC or si granular cast mo ay maging broadcast. Okay? So, madaming cast tayo po ang pwedeng makita sa renal failure. Okay? Sa patients na may renal failure. Imagine, sirang-sira na yung kidneys niya. Okay? So, lahat na ng pwedeng dumaan doon ay naiipon, tapos meron pang extreme urine stasis. Sa sobrang tagal na nung mga cast na yon, nag-degenerate na sila to become your granular cast at naipon sila, lumaki sila at duman sila sa mga malaking tubules, at while they're being formed, ina-adapt nila, okay, yung size ng mga widened tubules na yun. Kaya broadcast, okay sila. Okay? So most common are your granular and your waxy cast. Bakit? Kasi these are what? 'Di ba yung mga common na results ng cast na nag-disintegrate na. Okay, due to, prolonged urine stasis. Okay? Some naman are bilirubin stain, like for example, in viral hepatitis. Okay? So, next. Okay. So, guys, no, i-end ko na dito kasi it's 12:18. Okay? So, this is urinary crystals. Okay? So, adding, ano ba yan? Saan na ba yun? Paano na nga, guys? Okay. Okay. So, adding, i-end ko dun and I'll share you yung screen ko. Wait lang. Saan na ba yun? Okay. Save ko lang dun sa ano nyo. Sa lens. Okay? So, saan na ba yun? Okay, wait. Okay, ito. Okay. So, adding, nakikita nyo ba?
Yes po, ma'am.
Okay. So guys, no, for 3A, kung may time pa kayo, I have here the continuation video kasi it's 12, may pasok yung C ng 1 p.m. Okay? So it's a recorded video, okay, discussing now yung crystals natin. And please do watch this. Kahit kayo 3C, kung may vacant na kayo mamaya or sa ibang araw, pakipanood po ito kasi dito po dun sa lecture na to, tama. Dun sa discussion ng crystals na to, andito po yung presentation nung urine sediment atlas. Okay? So other than the pictures po na nakikita nyo dun sa libro nyo, this video contains then yung discussion, okay? Nung mga pictures na to, atlas, urine sediment atlas. Okay? So panoorin nyo to, guys. Ilan ba to? So, 1 hour lang naman siya. 1 hour siya. Okay? So, very lengthy kasi talaga. Okay, yung discussion ng microscopic exam. Kamukha nung sa chemical exam ninyo. So, adding again for 3A, kung may vacant naman na kayo mamayang hapon or may time pa kayo, okay, panoorin nyo to. Okay, lalo-lalo na yung sa last part kasi andun yung atlas ng urine sediments natin. And for 3C, you may do after siguro ng class ninyo or pag may vacant kayo or sa weekend. Okay, basta dito guys, mapanood nyo to, mapag-aralan nyo bago kayo mag-exam ng mag-quiz ka ng microscopic exam of urine. So adding next week, hindi mo na kayo magki-quiz nito. Ang quiz nyo po next week ay chemical examination of urine. Okay? Kailan nyo examine yung microscopic exam? Kasi ang alam ko po, midterm exam nyo na next week. So isasabay ko na lang yung microscopic exam dun sa midterm exam. Pero sana hindi tayo sasabay dun sa iba kasi di ba alam natin yung problema natin sa lens. Minsan, pag sobrang daming sabay-sabay nag-exam, ano po, na naglalag. Okay? So, ang problema ko kasi sa microscopic exam, pictures kasi. Okay? So, parang virtual moving exam yung dating niya. Parang ganun. So, picture kasi yon. So, kung makikisabay tayo adding dun sa ibang mga mag-exam pa na madaming first year, mga ganyan, baka mag-lag tayo. So, i-schedule na lang siguro natin guys yung microscopic exam ng ibang araw. Or I mean, a day siguro after yung midterm na lang. Okay? Basta yung hindi tayo makikisabay dun sa madami kasi sayang lang din na maglalaglag kayo tapos sasabihin nyo na hindi nyo na-take ganyan kasi na biglang nag-down si lens, mga ganun. Okay? So other than that, guys, please, watch din itong additional videos natin, related videos. We have here the preparation of urine specimen for microscopic analysis. Okay? So makikita nyo dyan how they're going to prepare, from sediment preparation to examination. Okay? And other than yung atlas na sinasabi ko dito sa recorded lecture ko, tignan nyo din itong urine sediment elements identification part 1 and part 2 video from YouTube, okay? So this will help you now, okay, to test yourself. Ay, na-identify mo na ba kung ano yung white blood cell, ano yung red cell doon sa urine sediment natin, okay? And for the atlas, by the way, na ginamit ko dito sa video na to, na continuation natin, kasi sa urinary crystals to mag-start, kasi mag-end na tayo ngayon. Continue nyo na lang dito yung lecture, okay? Guys, andito po yung, I don't know kung available pa ba to. This is the atlas, okay? So you just have to click this at ayan, mapupunta po kayo dun sa atlas ng urine sediment. Okay? So please review this, okay? Familiarize yourselves with the different urine sediment constituents, okay? So it's already 12:20, okay? So guys, dun sa mga estudyante na hindi po nakapag-attend kasi may mga ibang students, like for